Good morning, all. A lazy day and lazy beginning, of course, after yesterday's gala dinner and the last day of the conference. We will try to navigate you through this session. May I invite Dr. Pulkit Mittal? Is he around? Yeah, okay. He will talk about cerebral hemodynamic changes before and after cranioplasty using CT perfusion, a longitudinal observational study. Please.
Hello. Good morning, everyone. I am Dr. Pulkit Mittal, and I will be presenting my study on cerebral hemodynamic changes before and after cranioplasty using CT perfusion, a longitudinal observational study. This is the initial assessment of an ongoing study. Global Burden of Disease Organization defined the annual incidence of traumatic brain injury to be around 369 out of every 1 lakh people. Large cranial defects is a common sequelae in severe traumatic brain injury post-decompressive craniectomy. It has been shown to impair cerebral blood flow self-regulation. Cranioplasty, although thought to be a reconstructive procedure, improves cerebral hemodynamics and allows increased rehabilitation activities. Patients post-decompressive craniectomy show an array of symptoms, from headache, confusion, to sensory symptoms like affecting consciousness, memory impairment, and concentration impairment. They also show motor symptoms like weakness and gait disturbances. The aim of my study is to evaluate the cerebral hemodynamic changes quantitatively and qualitatively in patients undergoing cranioplasty. My primary objective is to study pattern of cerebral hemodynamic changes before and after cranioplasty for only traumatic brain injury. And secondary objective is to assess impact of hemodynamic changes on neurological and neuropsychological outcome. In the CT perfusion study, color-coded perfusion maps are calculated from the time enhancement curve. Regions of interest are placed on ipsilateral side and mirrored on the opposite side, which are basal ganglia, thalamus, and 1.5 centimeter below the cortical surface. The parameters studied are cerebral blood flow, blood volume, mean transit time, and time to drain. Below images show the color-coded maps which we get from the CT perfusion software. The neuropsychological outcome is assessed using these 4 tests which are mentioned below. These neuropsychological tests assess the executive function, which further has 6 components: planning, working memory, cognitive flexibility, inhibitory control, verbal influency, and processing speed. These 4 tests further assess these functions, which are trail-making test, Stroop color test, digit span test, and animal fluency test. A prospective observational study was conducted of 9 cases. This is still a preliminary study, and duration of study was 8 months. Consecutive sampling method was used. Outcome was assessed by neurological outcome, that modified ranking scale and Barthel score, and neuropsychological test as described. Patients undergoing cranioplasty after decompressive craniectomy for traumatic brain injury were included, and they are either going allograft implant or autologous cranioplasty with screw and plate fixation. Patients undergoing craniectomy for any other reason like stroke, neoplasm, or infection were excluded, and patients under the age of 18 years were also excluded from the study. As contrast was being used, patients with deranged renal function test and allergic to contrast were also excluded. Post-decompressive craniectomy patients are screened. MRS, Barthel index, and neuropsychological assessment was done before surgery. CT perfusion was done 24 hours before cranioplasty, and further 10 to 14 days post-cranioplasty. Neurological outcome was assessed at 1 and 3 months, and neuropsychological outcome at 3 months post-operatively. The majority of the patients in a study were male, that is 6 out of 9 patients were male, and mean age was 38 years. Only 1 patient had comorbidity, that was hypertension. The most common intracranial lesion at onset was subdural hemorrhage, and that was 7, and 2 patients had contusions. Craniectomy was done more on the left side, and the patients that were undergoing this surgery, 6 patients lied in the mild traumatic brain injury category, and 3 patients in the moderate traumatic brain injury category. None of the patients had any post-operative complications. The median interval between decompression and cranioplasty were 208 days. Patients had precranioplasty cognitive symptoms like memory loss and decreased word output. And in the pre-op CT, it was showing that 2 patients had encephalomalacia, 1 had subdural hygroma, and 2 had ex vacuo dilatation of lateral ventricle. And 8 patients underwent only autograft cranioplasty, and 1 patient had titanium mesh placement. The preoperative and postoperative MRS and Barthel score was calculated, and it showed that the MRS score improved and Barthel score also improved, but the improvement was not significant. Perfusion parameters were calculated for the craniectomy side and the contralateral side pre and post cranioplasty. And in all these regions as mentioned, basal ganglia, thalamus, temporal lobe, and frontal lobe. It was seen that the thalamus, that the cerebral blood volume in the thalamus improved significantly post cranioplasty and mean transit time reduced post cranioplasty. In the other regions, these changes were not significant. It was also seen that the cortical perfusion remained stable on the contralateral side pre and post cranioplasty. The Barthel score improved after 3 months, and it was seen that it has a positive correlation with cerebral blood flow, which means that as the cerebral blood flow improved at 3 months, Barthel score also improved. MRS score didn't show any significant improvement. These are the neuropsychological tests which showed that the digit span test and animal fluency test improved significantly at 3 months post-surgery. Thus, we can conclude that the cranioplasty influences the cerebral hemodynamics and has a positive correlation on the functional outcome. These data imply a possible role of cranioplasty in restoring flow to meet the prevailing metabolic demand. CT perfusion can be used as a promising tool for analysis of hemodynamic abnormalities occurring in traumatic brain injury. The strength was that the hemodynamic changes were compared with neurological and neuropsychological outcome. Limitation was that it was a limited sample size because it's still an ongoing study and short follow-up was there. However, this lays the groundwork for future studies. Thank you.
Thank you very much. I think very, very interesting and important study because we keep on doing a lot of cranioplasties without understanding how it benefits. We think only it is a cosmetic result which improves. So, but the benefits go beyond, far beyond than that. Thank you very much for this piece of information.
Thank you, sir.
The paper is open for questioning.
Thank you, Dr. Mittal. A very good paper. I do the same studies in stroke patients.
Yes, sir.
I use the Rapid software.
Yes, sir.
Which software are you using? And is it a cloud-based platform? And what about the data privacy? That's the first question.
We are using a Syngeo software that is there. It is deconvoluting software. In this deconvolution software, the radiation is also reduced to the patient, and it gives the color-coded maps as described. So it is a software in our institution only. It is not a cloud-based software, and data is secured in our institution.
Maybe you could share it with our stroke guys so that we could make use of it. That's
Sure,
one
sir.
thing. Second thing, these CBF we use in the acute stroke phase, as you know,
Yes, sir.
within 24 hours. And I found your post-cranioplasty at 10 to 14 days.
Yes, sir.
Now, that's a big time range you're using. And again, a second question was that, how do you know that the 10 to 14 days is the optimum period when to assess your CBF? Why not 7 days? Why not 21 days?
Actually, sir, these patients that come to our institution, they come from faraway places. Thus, I had to put a 4 days range so that none of the patients get missed out of the study. But we can, in the previous studies, they have used 7 days, some have used 14 days, some have used 1 month. They have been variable in the previous study, but they haven't included only TBI. They include stroke, neoplasm, all of that. Patients. But I wanted to study only traumatic brain injury, and I chose this outcome because then it will be easier follow-up when the patients come to us for the follow-up.
I was meaning whether the changes would be apparent within the first 5 days of cranioplasty or would be a late effect of the cerebral recirculation?
Sir, for this we have to do another follow-up CT perfusion at 1 month and another
study.
at 3 months to see the changes. This is still a gray area. Nobody is sure that when the exactly cerebral blood perfusion increases, when it decreases. So, we need to do more study in this area still.
And the last question, it was a very busy slide you put up about various different areas of the brain and a very complex slide. What's the sum and substance of it? Is the frontal lobes getting more perfusion? after the what's the summary of that slide? Can you bring it up? Because it is a very busy slide.
It showed that the thalamus, in the thalamic area, there was significant improvement in cerebral blood volume and decrease in mean transit time. That is, more perfusion was getting in the thalamus post cranioplasty. In the other lobes, like frontal lobe, temporal lobe, under the craniotomy defect, and even the basal ganglia, it didn't show much improvement.
Right.
So, thalamus is the area of interest for now in this study. But as we will take more patients and we will study more, maybe.
Thank you. Thank you, Pulkit. Thank you very much. And now, sir, I would like I just want one line from you.
Yeah.
You have done for stroke also.
Yes.
Just share your experience. Does it work? That's it.
It
Does
works.
it work? It works.
Collateral studies, collateral flow in the stroke patients.
Okay.
We can understand better, and it's actually a one step in advance of diffusion weighted MRI. So we have found good results, and we use that. Although the Rapid software is a cloud-based data privacy issue, 8,000 rupees per patient.
In nutshell, it works.
We'd like to, it's a very good tool to assess cerebral circulation within the first 24 hours. Hence my question.
Thank you.
Thank you, Dr.
Thank
Mittal.
you very much. Thank you. Yes, please. We have some time because people are very less in number.
Good morning, Tomorrow. Thank you for giving me the chance to ask a question. Outstanding talk.
Thank you, sir.
As you know, I'm not telling you anything you don't know, TBI is both an acute disease and a chronic disease. I was very impressed by your neuropsychological studies. A question, plea, suggestion, whatever you want to call it. Have you thought of doing extended studies, a year, 2 years afterwards? So what we really need is this longitudinal data of how these patients do, and look at the chronicity and the side effects, and maybe how a factor like a cranioplasty can influence that. Thank you.
Yes, sir, we wanted to do a longer follow-up, like even at 6 months and even at 1 year if possible. But now it's still an ongoing study. We are still recruiting more patients and doing follow-up. For sure, we will collect more data and present it. Sure, sir.
We've tried to do that. Just to forewarn you, recruitment and retention and getting these patients to come back is going to be difficult.
Yes, sir.
So, congratulations.
Okay, guys. Thank you very much. I think we'll move forward because not many people are waiting here. Please.
Thank you, sir.
Good morning, ladies and gentlemen. My name is Dr. Murali Manju. I am from Department of Anatomy, actually. I am not a surgeon, and I am from KMC Mangalore, Manipal Academy of Higher Education. The title of my presentation is Resveratrol Supplementation in Alzheimer's Disease to Reduce the Risk of Fall. It is a basic science research from rat model. Authors are Dr. Lakshmi Rao and Professor Amit Agrawal sir and myself. Can you move the next slide? Epidemiological studies reveal that 30% of patients who sustain traumatic brain injury have amyloid beta deposits and neurofibrillary tangles in their brain in patients of Alzheimer's disease. Resveratrol is basically an antioxidant. It is a polyphenol compound. It is found in some dietary sources like strawberry, cranberry, red wine, chocolates, cocoa, and peanuts. So this polyphenol compound having antioxidant property can be used in neurodegeneration. Donepezil is already a drug which is used in Alzheimer's disease. It is a acetylcholinesterase inhibitor. Eventually prevents the accumulation of amyloid beta. The objective of this basic science research is to study the effect of resveratrol and donepezil combination on the amyloid beta deposition and neurofibrillary tangles in different regions of brain. In Alzheimer's disease-induced model, Alzheimer's disease was induced by giving colchicine into the rat. Materials and methods. The study had 6 animal groups of 6 rats each. Group 1 AD model, colchicine was given to induce Alzheimer's disease. Group 2, resveratrol 10 mg was given after the induction of AD. Group 3, 20 mg resveratrol after induction of AD. Group 4, resveratrol 10 mg started before induction of AD. This is prophylactic dose, and 10 mg after induction of AD. Group 5, slightly higher dose, 20 mg was given before induction of AD and after induction of AD. And last group was resveratrol along with combination of donepezil. This was given 7 days after induction of AD. So this is a picture which shows the formation of amyloid beta. It's a 40x picture, immunohistochemical picture showing the amyloid beta which is seen in the Alzheimer's disease patients. And in this rat model also we observed after induction of, this is actually not exactly Alzheimer's disease, but Alzheimer's disease mimicking model by using colchicine. This is of different groups. You can see the picture here. And here we can compare. The better results were observed in donepezil along with resveratrol, which showed reduction in number of amyloid beta here. And 10 mg, prophylactic dose and post-exposure 10 mg was also beneficial. But this study observed that 20 mg was not beneficial. 20 mg, you can see with this violet color, more number of amyloid beta and neurofibrillary triangles. So this table shows the mean number of amyloid beta. We can see that better results observed in donepezil plus RS and 10 mg resveratrol, 20 mg, but no use of giving 20 mg resveratrol. The amyloid beta were increased. This is our second one, that is the neurofibrillary triangles. These are neurofibrillary triangles. Immunohistochemical staining was done with polyclonal rabbit anti-tau antibody. And this is showing the tau positive neurons of different groups here. And the same thing, the donepezil resveratrol was giving the better results as the NFT were decreased in this group. 20 mg was not beneficial, it was showing increase. 10 mg, 20 mg, 10, they were all beneficial. This is the mean number of neurofibrillary triangles. Best observation was in donepezil with resveratrol. 20 mg was not useful, it was showing more number of neurofibrillary triangles, almost the same as AD model. The oxidative stress in the Alzheimer's disease caused by intracellular accumulation of neurofibrillary triangles and extracellular deposition of amyloid beta. 10 mg, 20 mg resveratrol treatment groups and prophylactic group of 10 mg are decreased the deposition of NFTs and amyloid beta, showing the neuroprotective effect of resveratrol. However, slightly higher dose of resveratrol when given 20 mg before exposure, 20 mg after exposure showed toxic effects due to its pro-oxidant effect. The combination therapy of RS with donepezil was more beneficial, which indicates the synergistic effect of resveratrol and donepezil. The limitation of our study is actually it's not exactly a model of Alzheimer's disease. It is an Alzheimer's mimicking model. So better study can be done with the transgenic models of the Alzheimer's disease. Conclusion, the neuroprotective effect of resveratrol in this study suggests that supplementation of resveratrol is beneficial in Alzheimer's disease patients who are at the risk of falling during walking and standing and all, and sustain brain injury and other injuries. Our study observed that slightly higher dose of resveratrol was not beneficial, as it was showing toxic effect due to pro-oxidant effect. These are some of the references. We are planning to submit this paper for publication in index journals. I am thankful to the organizing secretary, organizing chairperson, Professor Sinha sir, and Professor Amit Agrawal sir, for considering my paper for this neurosurgery conference and allowing me to present this paper. I enjoyed coming this conference. Thank you.
Thank you very much.
Thank you, sir.
Yeah.
Thank you, Singh sir.
I think we'll allow only one question right now, because at the end we have some time for discussion.
Okay, sir.
Because the first paper somehow consumed a lot of time.
Okay,
so one question can be asked. I think everybody is very clear about it. Okay, please.
Yes, sir.
I'm not, but I'm very grateful that you have presented a basic science paper
Thank you,
in
sir.
this surgical conference. So thank you.
Thank you, sir.
I did not see a correlation of falls and amyloid in your entire rat model. You didn't put the rats on the rotor rod to assess whether they would fall more. So I wasn't sure about the topic and the selection, one. As
Yes,
you
you
said,
mean the trauma to the...
where's the correlation between the amyloid and whether the patients are going to fall, the rats are going to fall over, and whether the drug intervention will prevent the falls? That wasn't...
Yes, sir. That study can be done, sir. We can give trauma to the rat, and that we
Okay,
can...
so we
that
didn't
we
see
didn't
that.
study, sir. That it
And
can
the
be
second
studied.
point was, you said about the transgenic, there are better Alzheimer's models, knockout
Yes,
mice
sir.
models.
Transgenic models, yes, sir.
And I wasn't sure about the effect of this particular chemical from the data you presented.
Yes, yes, sir.
Because it was entirely a acetylcholinesterase effect that you were showing, which
Yes,
was
sir.
the better. So
Yes, sir.
we need to, but thank you very much, because basic
Yes, sir.
science is what
Yeah.
we need to do.
I
Thank
think
you, sir.
that-
Yes, sir.
I think
Thank you for the
guys-
valuable suggestions.
Guys, let's move forward, because there is a question answer and they have to leave for the airport also.
Okay, sir.
May I invite now
Thank you,
Dr.
sir.
Adrian Jacob, and he will talk about impact of timing of cranioplasty, institutional experience.
So good morning, everyone. I'm Adrian. I'm from Apollo, Chennai. I'm going to talk about our experience and the impact of timing on cranioplasty. Yeah, so we all know that decompressive craniectomy is a potentially life-saving surgery which is done in patients with medically uncontrollable high ICP, which is seen in intraparenchymal bleeds, infarcts, diffuse cerebral edema, seen in traumatic brain injury. And cranioplasty is a way of reconstructing the calvarial defect using different materials, and the usual indications are to first reconstruct the calvarium and also to prevent decompression-related complications like fluid collections, altered CSF flow, altered blood flow, psychological consequences, and also sinking skin flap syndrome. Cranioplasty is usually performed in the absence of medical contraindications and infections, and the complication rates do vary from 12 to 50%. So the timing of cranioplasty is considered a modifiable risk factor. In the literature, the definitions of timing are a bit ill-defined. There are multiple studies where they have different definitions. As you can see, early could be less than 10 weeks or less than 12 weeks or less than 3 months. So we use the definitions which were agreed upon in the 2018 ICRAN consensus, which is that ultra early is up to 6 weeks, early is 6 weeks to 3 months, intermediate is 3 months to 6 months, and delayed is more than 6 months. So why think about this? So early cranioplasty could have possible advantages of decreased time at risk for the injury to the unprotected brain, could lead to easier dissection during surgery, earlier improvements in cognitive functions and neurological deficits, and also could have lower costs since the patient would be in a single hospital stay. The possible disadvantages are that maybe higher infection rates, and also the other complications associated with cranioplasty is another hit very close to the first decompression. So in the literature, we see that one study showed there's an overall complication rate of 18.9% with higher complications in early cranioplasty. There's less than 10 weeks in the study, but with no relation with hydrocephalus. Huang et al. Showed that the infection rate peaked at 7 to 9 months, though not statistically significant. The largest study till now was with 754 patients, where the infection was highest within 14 days. Hydrocephalus was highest when the cranioplasty was done within 90 days, and seizure risk was highest after 90 days. So they at the end advised to do a cranioplasty between 15 to 30 days. So if in our experience, we had around 113 patients from 2017 to 2023, 18 patients were lost to follow-up, so we analyzed the records of 95 patients. 44.8 years was the mean age of the patients, and we had only 3 pediatric patients. 84% were male, and we had a fairly nearly equal distribution on the side, with the 52% of the patients having a right-sided cranioplasty done. So the etiologies for decompression were mostly trauma, 50%, followed by infarction and intraparenchymal bleed. Some of them did have CVT, aneurysmal rupture, or tumors. So we had a fairly good number of patients in each timing, most of the patients getting an early or an intermediate cranioplasty done, and we tailored it based on the clinical status, resolution of edema, whether the patient had a sunken flap syndrome, and the patient and relative factors like cosmesis and affordability. So we had an overall complication rate of 16.7% at a follow-up of 6 months. 11% was infection, and we could see a spike of infection in the early cranioplasty. So in the literature, we do see that one review and meta-analysis showed that there's no significant association with timing and infection. Another one also concurred the same. But there was one study which showed timing of cranioplasty in hemorrhagic stroke had higher complications with early cranioplasty. Another one showed that it was higher in late cranioplasty. Our hydrocephalus rates were 16%. That also showed a spike in early group, but 90% of them were shunted before the cranioplasty.
Delegates, today I will deliver topic cranioplasty after post-traumatic decompressive craniectomy. As we all know, decompressive craniectomy is potential life-saving procedure in patient who is medically refractory hypertension. Its efficacy is still controversial. There are so many studies still going on. Contrary-wise, there is general consensus regarding the necessity of the cranial reconstruction following decompression craniectomy. So cranioplasty is defined as restoration of a defect in the cranial bone or correction of deformity of one that may happen after trauma. So cranioplasty is done following decompression, aims basically to restore the aesthesis, improvement of the CSF dynamics, because after decompression craniectomy, there is a change in the CSF dynamics. So our cranioplasty aims to improve this CSF dynamics, and they're furnishing a cerebral protection, because after decompression craniectomy, there is no protection to the brain. So this cranioplasty also aims to protect the brain. These event consequences to ease the neurological rehabilitation and potentially intensify the neurological recovery. It is not a newer technique. It is used to bridge the bone defect after decompression craniectomy. Initially, patient's own bone was used, but now there are various artificial materials available for the cranioplasty. India is a developing country, and there is a very high incidence of the road traffic accident and number of decompressive craniectomy and the cranioplasty are performed. Still, there is no concession regarding the type of the material for cranioplasty and timing of the cranioplasty. Coming to the history of the cranioplasty, they are basically they are divided into three zones: ancient, modern, and the recent history. So in ancient history, in the era of the 3000 BC, there were for the head injury there were the trephination done, and they have seen that in the nearby skull there was a gold medal, straw metals. So they thought that gold were used for the cranioplasty. In the modern era, first description of the cranioplasty was given by the Ibrahim bin Abdullah in 1505. He used the xenograft material, especially the dog's cranium was used for the cranioplasty. The first true description was given by the Fallopius in 16th century in the form of the gold plate. Autograft, most common used nowadays the autograft in India because of the money problem. And other substitute are used, the methyl methacrylate and 3D mesh, titanium mesh are all used. So what are the common material which are there? So there are no any ideal material used for the cranioplasty. So ideal material must have the following feature. They should fit the cranial defect, it should achieve the complete closure, it should be radiolucency, resistant to infection, not dilated with the heat, and easy to shape, and it takes the contour of the brain, and it should be ready to use, and it should be not expensive. Still, there is no any perfect material to fit all these criteria. So most common use the autologous bone in developing country because of the money problem, and it is used for filling the small to medium sized graft as well as even the large cranial defects following the advantage is biocompatible and cost free. Disadvantage because of the bone, as the bone fill up undergo resorption, there is a chances in the breakdown and requiring the reoperation. Titanium mesh, it is used either as initially it was used the plate, now it is available in the mesh form. Mesh form, it provides the osteointegration better than if you use in the plate form. And it is available with varying stiffness and degree of openness. It is associated with a better cosmetic as compared to the autologous bone. PMMA, very common material, used either as a liquid form or the solid form. Liquid PMMA is a non-observable, radiolucent, inert, and effective and affordable choice for the cranioplasty. Solid custom-made PMMA is easy to contour and as well as texture surface. Another is a polyether ketone. 3D prosthesis. 3D prosthesis shape is another important factor for the successful cranioplasty. In neurosurgery, 3D printing can be used to create the prosthesis and molds to reconstruct the cranial defect using the CT data to obtain the dimension and shape of the repair. But the cost of equipment, lack of knowledge and training, and introduction of the commercial FDA-approved media for printing are thought to be obstacle to widespread adoption of the neurosurgical 3D printing usage. Timing of the cranioplasty. There is still no data regarding when we should do the cranioplasty. Either it should be done early or the late. Early means within the 6 months after decompression craniectomy. Late if it is done more than 6 months. So concept of Clinical status and infective status are strong determinants of the outcome of an early cranioplasty and paramount importance in establishing the timing of the early cranioplasty. These are the some studies showing the timing of the cranioplasty. So Chun and Wai study, they have performed early cranioplasty. They have showed that earlier cranioplasty has low complication rate as compared to the late cranioplasty. These are the some studies. In these studies, they have shown that the early cranioplasty has better outcome than the late cranioplasty. So these are the case reports, some case reports from our institution. So this is a 35-year male patient presented with the RTA with on admission the GCS was E2, VT, M2, and patient is having the left side left FTP SDH with multiple contusion. Patient undergo left FTP decompression craniotomy. This is the post-op scan. This is the showing the sunken flap, and we try to use the first the autologous bone, but because of the brittle on intra we find this bone was brittle, so we use the titanium mesh. This is another patient, 24-year male patient with RTA on examination presentation. GCS was
Dr. Raman, I think you have to wrap it up fast.
okay. GCS was E2, V1, M2. In this patient, we use the bicoronal autologous craniotomy. So in our study, the total number of cases, 40 patients in 1 year. Timing of craniotomy varies between 2 to 6 months, in which 21 autologous band, 14 titanium cage, and 3 PMMA. In which case 3 bone flap was removed because of the infection. So conclusion, timing of CP should rather be based on objective case-by-case assessment of the neurological status of each patient, resolution of brain swelling, and complication associated with the large calvarial defects rather than arbitrary time window, and should be performed as soon as brain swelling resolves on CT scan, provided that the patient is not in infectious state. Thank you.
Good morning to all. Today my topic for presentation is demographic profile. Clinical feature, imaging and outcomes in patient with traumatic brain injury presenting at tertiary care hospital in Garhwal region of Himalayas. Traumatic brain injury, major healthcare financial burden, major public health problem, leading cause of trauma-related death, disability worldwide. In India alone, 1.5 to 2 million individuals sustain injuries annually, more than 1 million deaths. Alcohol involvement in confounding factor in 15 to 20% of traumatic brain injuries cases at the time of injury. Approx 60% cases due to RTA, 20 to 25% due to falls, 10% due to violence related. Diverse profile influenced by age, gender, socioeconomic factors, and geographical location. Clinical manifestation range from mild concussion to severe injuries. After clinical assessment, CT and MRI are cornerstone of thorough evaluation. Short-term and long-term patient outcome depend on integrated approach and identification of multidimensional aspects of TBI to tailor rehabilitation strategies. Our aim is to analyze the demographic characteristic, clinical feature, imaging findings, and outcome in patient with traumatic brain injury presenting at tertiary care hospital in Garhwal region of Himalayas. We have a retrospective and prospective study of patient presenting with traumatic brain injury at Shri Mahant Indresh Hospital, Dehradun. The study was conducted between September 2022 to August 2023. The study includes 490 patients. Patients of all ages presenting to emergency department with confirmed diagnosis of traumatic brain injuries were included. Cases with complete demographic, clinical, and imaging data available for analysis were included. Patients with incomplete or insufficient medical records were excluded. Individuals with pre-existing neurological conditions affecting the interpretation of TBI outcomes were excluded. Data on age, gender, socioeconomic status, and residential location were extracted from medical records. Clinical manifestation, mode of injury, and comorbidities, GCS on admission and discharge were documented. Imaging findings were analyzed for structural insights. Based on GCS, TBI were graded as mild, moderate, severe. Duration of hospital stay and stay on ventilator were noted. Outcomes were assessed using Glasgow outcome scale. The results were as follows. 30% of patients were in the age group of 21 to 40, and 22.2 were in the age group of 0 to 20, and 28.2% of patients were in the age group of 41 to 60. 16.10% were in the age group of 61 to 80. Out of all patients, 76% of patients were males, 24% of patients were females. 81.8% of patients has no comorbidities, 12.4% has hypertension, 5.9% patients have diabetic mellitus, 2.9% of patients have CAD. Out of all patients, 30% of patients have history of alcohol habituation, while 70% don't have. The most common mode of injury was road traffic injury, contributing for 44%, then followed by history of fall, that leads to 41%. Most of patients present with vomiting, that contribute to 41.4%, and followed by headache and loss of consciousness, that contribute to 26.5%. Most of patients present with moderate GCS score, that contribute to 46%, and 32% of patients were with severe GCS score, and while 22% were patients presented with mild GCS score. On imaging findings, we found that 64.5% of patients have bony fractures, while 26.9% of patients have cerebral edema, 23.9% patients have subdural hematoma, 11% of patients have subarachnoid hemorrhage, while 4.8% has extradural hemorrhage, 0.6% has pneumocephalus, 19.2% has contusions, and 2.04% of patients have diffuse axonal injury. Out of 490 patients, 311 patients underwent conservative treatment, while 179 patients underwent surgical intervention. Out of surgical intervention, 16.75 patients underwent burr-hole surgery, 64.8% underwent craniotomy, while 17.8% underwent decompressive craniectomy. Out of all 100 patients were on ventilator support during the time of admission, during their hospital stay, and 79.96% patients don't need any ventilator support. On the basis of duration of hospital stay, 410 patients have stayed between 0 to 10 days, 60 of patients have between 11 to 20 days, 14 between 21 to 30, and only 6 patients have stayed more than 30 days. 81.4% patients have good recovery, and 8.36% have moderate disability, 1.8% patient has severe disability, 1.4% patient have vegetative state, and 6.9% have mortality during the. So our study comprised 490 patients, predominantly age 21 to 40, with male-female ratio 3.1:1, whereas other studies which patient affected were between 21 to 30 with ratio 2.2:1. RT, in our study, RT were most common mode of injury, followed by fall from height, which was comparative to other studies. In our study, at time of presentation, maximum number of patients had moderate GCS score, whereas with other studies, they have mild, 9.1% patient has mild GCS score. Or in imaging, our most common finding was skull bone fracture, followed by cerebral edema. Whereas in other studies, subdural hemorrhage contributed to 32.7%. Similarly, in our study, 63.5% were treated conservatively, and 43.9% underwent surgery, whereas in other studies, 69.7% treated conservatively, and 30.2% underwent surgery. At discharge, majority were conscious with favorable outcome. So to conclude, in our study of 490 patients, apart from road traffic injury, fall from height were primary mode of injury, presented with moderate head injury. On CT scan findings, 60.4% patient has skull fractures. So all patients with severe head injuries do not have poor outcome. Aggressive and timely management of all patients is necessary. The study emphasizes the significance of comprehending demographic, clinical, and imaging aspect of effective TBI management and prognostic evaluation. Since our neurosurgery department at SMH Hospital was established in 2020, our plan is further to continue this study in order to collect more extensive data so that we can better analyze the trauma pattern along with any modification in treatment strategy if required, which will benefit as well as patient of our. Thank you.
Can I make one comment? This is the data from a hospital.
Yes.
But actually, demographically, it doesn't represent the region, And I'm sure, given by the statistics all over the world, the mild head injury constitute 80%, which never report any. Remote areas, they have mild head injury, 1 or 2 days, they're fine, they don't come. So to say that is Garhwal representation, probably a little bit
So
of...
we will adding more patients.
Yeah, but then you have to go to the government level also, government hospital, local hospital, that would be the
We will
Garhwal.
be adding
Garhwal.
further to this study
Yes.
in future.
You have to include the broader population.
Broader aspects.
Yes, that's very important.
Thank you, sir.
Good morning, everyone. I am Paurush Pasricha, and I'm presenting our series on protocol-based early decompressive craniectomy in a resource-constrained environment, a tertiary care hospital experience, with Dr. B.K. Mishra being my senior author. Acute brain injury is a leading cause of death and disability worldwide. Major cause of acute brain injury include traumatic brain injury, malignant cerebral infarction, intracranial hemorrhage. Decompressive craniectomy is a last-year measure for refractory intracranial hypertension, that is RICH. Role of decompressive craniectomy in countries with low neurocritical care and neurosurgical resource is under the scanner, and protocol-based early decompressive craniectomy could be offered to patients with RICH diagnosed on the basis of clinical and radiological features. This is for the first time in literature that obliteration of basal cisterns as a grave sign was presented by my senior author in January 1984. And in the same year, in September 1984, a similar paper was published in the Journal of Neurosurgery. So our study is a retrospective and cross-sectional study that is over a period of 10 years, includes 58 patients, and we use Glasgow outcome score extended at 6 months and 1 year to analyze the functional outcome. Patients with no positive response to medical management, Marshall score equal or more than 3, GCS less than 8, or with GCS of 9 to 12 requiring ventilation, plus minus signs of clinical signs of herniation is the predetermined criteria we've used to diagnose RICH and to offer decompression. The median age of presentation was 44.1, and male to female ratio is almost 2:1. The majority of our patients were in 31 to 60 years of age, and ICH is the most common cause of RICH in our study cohort. Pupillary reaction was abnormal in 36% of patients, and the motor component of GCS was 1 or 2 in 17% of the patients. 65.5% patients underwent ICP monitoring in the postoperative phase, and hyperosmolar therapy was continued based on the ICP monitoring postoperatively. This is the results at 6 months. The cutoff of favorable outcome was the Glasgow outcome score extended 4 to 8, and unfavorable was 1 to 3. The most common outcome we got was upper severe disability, and in comparison to 12 months, the number of patients and the percentile in the good recovery group had significantly increased, and the patients with death or vegetative state had slightly increased or were almost the same. The favorable outcome in patients of traumatic brain injury, ICH and malignant cerebral infarction was 57.1, 58.8, and 85.7% respectively. Decompressive craniectomy is an emergency life-saving procedure used to treat RICH. While many studies have shown the efficacy of decompression in reducing ICP and decreasing mortality, others have questioned its usefulness. DECRA trial done in 2011 that included 155 patients showed the results that decompression lowers ICP and the patient spends fewer days in the ICU, but there is greater risk of an unfavorable outcome, and there is similar mortality at 6 months between the surgical and the standard care group. But this trial was criticized for the fact that recruitment criteria was that ICP more than 20 mm of Hg for 15 minutes was used, and this did not necessarily indicate RICH, and any potential benefit that was derived from decompression might be lost by surgical morbidity. A rescue trial that was conducted to assess the effect of decompression as a last-year therapy in patients with TBI and RICH that included 400 patients and were divided in decompression and medical care group. The results at 6 months suggested that decompression contributed to lower ICP and mortality rate, and there were higher incident of vegetative state, lower severe disability, and upper severe disability as compared with the medical group. And a secondary analysis that was done at 24 months of the same patients showed that patients had sustained reduction in mortality, higher rates of vegetative state, severe disability, and moderate disability as well. Patients in the study group, in the surgical group, were more likely to improve over time versus the patients in the medical group. Malignant cerebral infarction leads to space-occupying brain edema, resulting in raised ICP and brain herniation. As per a meta-analysis, they concluded that significant survival advantage was associated with decompression in patients of all ages when it was performed within 48 hours of onset of stroke. And currently, there is no reason to use a watchful approach for decompression after diagnosis of malignant cerebral infarction in a young patient. All the random clinical trials and majority of the literature available that have studied the role of decompression as a last-year procedure for RICH is based on continuous ICP monitoring, but the same is not economically feasible in most neurosurgical centers in low and middle-income countries with resource constraints. There is a lack of formal pre-hospital setup, insurance coverage, neurocritical care, and neurorehabilitation in LMICs. So some papers have looked into the role and timing of decompressive craniectomy in limited resource environment. This is a paper published by Alali et al. In 2018, where they presented a clinical criteria rule for diagnosis of raised ICP, which was statistically proven, and it coincides with the criteria that we have been using at our institute. So in conclusion, decompression clearly demonstrates a survival benefit in patients with acute brain injury with RICH in all age groups. Decompression helps in obtaining a favorable outcome in selected patients with defined pathology. Early decompression results in a better outcome and is significantly promising in malignant cerebral infarction. The take-home message is that it is imperative to communicate the potential range of outcomes and the expected quality of life with the next of kin of the patient to help in decision-making. Decompression is a viable last-year option against RICH and acute brain injury, and future studies that focus on quality of life and psychological status of the patient's post-decompression are therefore warranted. Thank you.
Okay, friends, I think that's the end of the session. We can take 1 or 2 questions at the max, please. Just 1 or 2. Short questions, no commentary, no comments, please. Okay, thank you very much. So we finish it off here.
Two minutes. It is 9:20. 9:22 we start? Yes. Okay. So I've been asked to wait for 2 more fortunate guys, so let them come so that they can also have the advantage of this quiz. We start at 9:22.
You can spread out. You can spread out on the various tables, okay?
Comfortable, be seated, and I will request all the participants to be seated on the first row. And there are a couple of rules here. So before we start, so let me introduce you to the rules. You have 20 questions, which are multiple choice questions, but with only one answer. I repeat, only one answer is correct. And the time allotted to answer each question is 40 seconds. So the question will be displayed over here on the projection screen. I will read out the questions to you, and you can also read from the screen. The question will be displayed for 40 seconds. Whosoever replies first will be given a priority in the marks calculation. So out of these, this is your keypad where you have to register your responses. And you can see A, B, C, D, E, F here. So this is for the responses. So out of these, only 4 responses, 1 out of 4 responses can be correct, like A, B, C, D. So please do not consider E and F. There is no E and F here, okay? So you have to answer amongst A, B, C, and D, and that's only 1 response. I repeat, only 1 response, okay? So after the completion of the 20 MCQs of 40 seconds each, your responses will be tabulated, and there will be 3 winners, number 1, 2, and 3. And the first winner carries a cash prize of 5,000 rupees. Second winner, 3,000, and the third winner, 2,000 rupees. So I wish you all the best, and do your best. And anything else which is left to tell? No? That's it? Okay. So brace your bells, go ahead and reply with a cool head. Remember, only 1 response, and the fastest fingers first. Maybe 4 of you might have replied the same answer which is correct. The person with the quickest response will be counted as the winner of that question. Okay? So the prizes and the will be distributed in the valedictory function today after the tallies have been tabulated. Okay, so with this we start, and I would request the audiovisual guys to project the first question, which goes as cerebral herniation syndromes regarding ascending transtentorial herniation. The false answer is, you can read that, I don't want to disturb you. Timer.
Screen, print that corner, second slide.
Okay. The second question goes, the oculocephalic reflex. The false answer is Can I have the third question, please? Third question is ICP measurement. The false answer is fourth question, ICP monitoring devices. The false answer is fifth question, ICP waveforms. The false answer is sixth question, pediatric TBI. The false answer is Indications to perform a head CT within the first hour following TBI. All are true except. Indications for a head CT in acute TBI, Canadian CT head rule. The false answer is hypothermia in TBI. All are true except. Scalp lacerations management, the false answer is traumatic CSF leaks. All are true except. Tension pneumosyphilis management. The false answer is subdural hematoma. All are true except. Osteoporotic spine fractures. The false answer is spinal shock. All are true except. TBI infections. The false answer is spinal cord injury without radiographic abnormality. All are true except. Cervical traction. The false answer is type 2 odontoid fractures, factors associated with non-union. The false answer is and here goes the last one, jumped facets. What is not true? Okay, so that's it. And your responses have been recorded and logged in the computer. So give us a while and the final, after the tabulation, the final results will be announced in the valedictory, as I previously said. Thank you so much for being in here and being patient and sitting and answering and making this MCQ session. Thank you so much.
Thank you, Dr. Sinha. So we can all move into the plenary section. The chairpersons for the plenary session are Dr. N. Muthukumar, ex-HOD, Madurai, and Dr. Peter Hutchinson.
The first plenary lecture will be delivered by Dr. Lokendra Singh, who is the Director of the Central India Institute of Medical Sciences. He is also the past President of the Neurological Society of India. Dr. Lokendra Singh, please. I think we have 15 minutes for each lecture, and then we have a 10-minute discussion at the end. Is it okay if we have the discussion at the end?
Yeah, sure. My dear friends, somehow the doctor bashing has become a new sport in Indian society. And that's very unpleasantful, very demoralizing, but unfortunately it's happening. The violence against doctors has been on rise, as you can see from the news cuttings, but is it only India? Not really. All over the world, the intolerance is increasing, and patients and their relatives are becoming more and more intolerant. Any part of the world you go, but in India somehow it is much more. Even the suicides by the doctors have increased. And perhaps the percentage of suicide is much higher in doctors as compared to public at large. A psychological autopsy was done of 38 doctors who committed suicide. That was done in England and Wales from 1991 to December 1993. 65% had depression with drug and alcohol abuse. 65% had significant work-related problems. 39% had marital relationship problems due to work-related issues. Only 10% of people from this group had their personal issues or financial issues. Rest were all work-related with their professional work, actually. Friends, the healers are wounded, both physically and psychologically, and they need healing. So, healing the healers is a new sort of a therapy needed for the medical profession. It is not doctors alone, as I said, teachers, preachers, government officials, they are subjected more and more to the violence. But of course, we are more concerned here about our own group. There is no part of society which doesn't really involve or indulge in maligning the medical profession, be it politician, activist, judiciary, journalist. Sometimes they all sound against doctors. The reason is, for a cheap popularity and publicity, they indulge in all this. And then somehow we are plagued, as medicos, we are plagued by wrong culture. If you are in private practice, the low fees competition is there, patient pleasing at all costs, 24/7 availability, proud stories of inhuman working hours. We take a lot of pride in that. Oh God, I didn't sleep for 3 days or 3 nights. So directly the seat is booked for you in heaven, as if. We are setting up a wrong culture of self-exploitation. You see, people have been issuing guarantee cards that if your disease is not, ailment is not cured, I'll refund your money with interest. Now, can you believe that? And wrong cultures, again, in the form of doctors, are the worst enemies of doctors. Unhealthy competition, upmanship, they indulge in backbiting, ridiculing, amusing, accusing, and abusing their own colleagues. And they conveniently forget that next time they may be on the hot seat. And that's why sometimes we see inscriptions against doctors on the tombstone, or sometimes on the letters which are sent on the death of a relative to other people, that so-and-so, we, with great sorrow, we inform that my this and this relative died because of the carelessness of a doctor, so you are invited for the ceremony. So doctor's name is just added there. This is unfortunate, but this is happening. There can be many causes of violence, we understand. The poor funding, logistic problems, poor staffing, public perception is going against medicos, that medicos are supposed to just, they're bloodsuckers. They're leeches, as if. This is, I've seen in US also. When I traveled there, even taxi drivers were against doctor. Oh gosh, they're looters, they're looters. Hostile media, activists, politicians, and even the judiciary, which I have already mentioned earlier. My dear friends, it's a changing world. The status, respect, and reputation of all professions is going down. It's a changing place, and the social equations are changing. It's an era of faceless Facebook, virtual friendship, virtual meeting places, Uber, Ola, Swiggy, Amazon, and surefire results of everything, which unfortunately a medical professional cannot provide. There are no ready-made solutions which they expect from us, and they want immediate gratification which we can't provide. So either we are deities or demon, and sometimes now people have started considering for technician also, which I prefer. As a deity or demon, I'll prefer to be called a technician. But you see, the perceptions have been changing. What to do? That's an issue. What to do? Well, we are doctors. We have been treating with the ailments, body ailments, and this is ailment of the society. I believe perhaps the way we approach it will remain almost the same the way we approach an ailment of a human body. Take the history. We should understand why it happens, with whom it happens, what group of people do it, what are the various issues where it is most common, because this all I have done at my place, data collection, then data examination, and find out the pathogenic factors. What causes what and why? And then inspection, palpation, and auscultation, because inspect yourself also, inspect other issues also. Try to grasp when the problem can start. You can find out very soft signs when you know that probably something is brewing up and it will explode. You know it. Even when you're talking to relatives whose patient is not doing well, from their body language and stance, you can understand that this man probably may try to hit me, or abuse me, or try to, intimidate me. One should develop protocols. In my hospital, I have the protocol that if there's a problem, there are bells everywhere. So you press a bell, people from all the floors will reach there. So bell is there. I just wanted to demonstrate that this is how it works. Right. Then training and retraining of the staff. The staff needs to be trained, my dear friends, because the problem is our staff doesn't know. They just treat patient like a patient, and relatives is a very secondary issue for them, and it is the relative which creates a problem. So I think we should understand how to tackle them, how to, give them some, maybe if he is crying, give a paper napkin, or if he's there, give a glass of water. This all protocols we have started, and this works. We should have knowledge of various psychological aspects of patient. I'll talk about them later on, and relatives' behavior, and make a strategy accordingly. CCTV, panic buttons, redesigning the casualties, because there should be space for the people to sit there where they can be calmed down. Security staff has to be there. And of course, you should have insurance, otherwise your property is lost forever. But my dear friends, whatever you do, the most effective still remains the time-tested kindness, empathy, and compassion. In medical profession, these cannot be replaced. As a young doctor, we try to, feel like a hero. Okay, I'll bash them up, and, I'll keep a gun and this and that. This is not what we are. So because just a minuscule of the people of the society misbehave, that doesn't mean that we should really change our character and what we are meant for. So kindness, empathy, and compassion are still the cornerstones. The few important facts we should know that majority of aggressors are not criminals. A lot of psychological studies have been done. The only people who create problems are probably blackmailers, extortionists, opportunists of low-level politicians. They are the people who create problems. Majority of society doesn't do knowingly all this. And a detailed study, as I said, psychologists have done, and they found no psychopathological trait in human beings which will really make them to do this. Apart from if they are criminals, then it's a different thing. Actually, they are ordinary people caught in extraordinary situation. They don't know how to deal with such a crisis. You will remember that how they behave sometimes, because then later on they come and apologize. Like a caged animal, the basic instincts of anger, flight, and fight, they replaces the common sense and the wisdom. We should understand this as a doctor. You see, these things don't work. Law, government rules, legal penal provisions are largely ineffective. If it was so, rape would not have been there, murders would not have been there, nothing would have been happening in the world. World should have been a utopian place. It is not, in spite of all deadly rules. These things don't work. Martial training of doctors, paid goons against aggressors, weapons, ferocious dogs in the OPD. This has been suggested, believe me. But still, you shouldn't do this, but you should have a zero tolerance policy towards violence. And my dear friends, mind your own backyard also. Please remember and introspect what you are doing. Doctors are many times, they behave irrationally when they go to other hospitals. I have seen it umpteen times. When they go to other hospitals, they are very, very irrational, demanding and abusing and accusing in my hospital, this and that, you are useless people, etc., etc. And please don't pretend God you are not. You are just a human being, a mass of protoplasm, okay? Don't get cocooned, don't cut off from the society. Many times we are told, no, we should not mix up with we should not socialize with the public. This is useless. We are born as human beings, not as neurosurgeons or doctors. This is just our profession. We are a part of society. We have to be with the society, and every human being is not your money bag. And don't listen to silly rules drafted by some office bearers of medical association. A rule was drafted in my area by IMA, Indian Medical Association. If at all you have to take alcohol with some civilian person, as if we are fighters, take only 30 mils, at the max 60 mils. And these are silly rules, and who drafts them and why, I don't know. Remember, please, there are other side of story. Try to concentrate on that other side of story also. Inspection, introspection, self-examination is the need of hour. Self-actualization is needed. Are we mere technicians? Are we officers, soldiers, or commandos? Or we are healers? We are not wounders, for God's sake. Remember, we are the chosen ones who are the only ones who touch the psyche and soma of another human being. Nobody else can do that. Understand the human behavior. Because as doctors should understand the human behavior governed by intricate psychological aspects. We humans are an amazing combination of basic instincts of animal kingdom enveloped by acquired traits of civilization over centuries. And basic instincts are the immediate reflex reactions which are controlled and rationalized by wisdom. But when situation goes out of control, this all is blurred. Wisdom is blurred, and the basic instincts take the driver's seat. This book is fantastic by Hans Rosling, The Factfulness. It's an amazing book. I have been reading it, and it helps a lot to understand the human psyche. The few hard facts. The journalists and activists and politicians are the instigators. It's their job. They survive on this. They are agenda-driven people. And you are not the only ones who are suffering in this changing world. A large number of people are suffering, my dear friends. There are very few professions in the respect which command respect, very few professions. And doctors and teachers and preachers are on the very high pedestal, still today, even today. And one thing you should remember, disrespect comes always in multiples when it is generated against a very, very respected person. It comes in multiples. And that's why reaction against us is very, very horrendous, very much more than the problem. Isko band karo bhai. Yeah. So self-help and self-healing is the need. Doctors who is stressed out and depressed and scared cannot treat anyone. And you are not Atlas, for God's sake. You can shrug your shoulder when needed. Life is not all about money, if necessary. It is necessary, but really it is not mandatory. Be kind to yourself and your near dear ones. Let the child within you thrive, enjoy life. There are three types of people, lion, deer, and swine. You know the swine. So please don't become a swine. Okay? Life is a beautiful cocktail of professional, personal, and social ingredients in right proportions. Enjoy it. And first me is the need of our age. It is not that me, where sex exploitation of females was started a movement. It is for doctors, first me. I should look after myself and my family. This is one of the approaches said by somebody that we should look at every case as a medical legal case first and then medical case. Well, you decide what you want to do. This is just in lighter vein by a WhatsApp guru. You see, you are not the only one who came here. This patient doesn't belong to me or doesn't belong to him. That sort of a gyan is there. There's a doctor's Bhagavad Gita I kept for lighter vein. I have been writing a lot about this. You see, you need a journey to take within yourself. And it is not as bad as we think. Probably we listen the same news 10 times from different channels and read on different newspapers. So it multiplies in our mind. So we think, oh God, it has gone so bad. It is not that bad. It's happening everywhere. Come on. And mindfulness is extremely important. Once you have decided to become a doctor, behave like a doctor, work like a doctor. So doctor profession still remains number one, even today. So please, you should read these books. Bhagavad Gita is my book. I read. Life is only once it comes, it's YOLO. Enjoy it. It's a cocktail, drink it slowly and nicely. Thank you very much. It's my city, yeah. Jaipur is my city. Yeah.
We all know him as a philosopher. Besides neurosurgeon, he's a philosopher. He's a youth icon. He's a poet and multifaceted personality. So who else would be raising this problem, burning problem in India? And we are very thankful that you have written a lot of papers and editorials in the paper. We are very thankful to you. Thank you so much.
Thank you. Thanks a lot. Thank you.
Right. Thank you very much, Mr. Chairman, Chairpersons. I'd like to thank Professor Sinha for really giving me this invitation. So when I was asked to speak on, head injury, I'm a pediatric neurosurgeon, so we deal with head injuries, but maybe not this, well, there's much smaller proportion compared to what the adults do. So I thought we'll talk about this, the way we see head injuries in the developed country, because a lot of literature is about, what's happening in poor resource countries. So it's very different. So I'll talk a little bit about, our burden of minor head injuries, and then just look at one of the studies that was done on concussions. Okay, and I have to thank my colleagues, Puisan, Liping, and Sharon for really helping me with this paper. So you can see Singapore is a tiny little dot right in the middle of the Southeast Asia, and it's about 275 square kilometer area. That's it, right? And but even then, you can get from one end of the country to the other in about half an hour. Right? And so this is a total area, and yet, we, because of the development, because how the country grew over time, we don't have natural resources except people, right? But the government's been using us very well in terms of finance and so on. So actually our per capita now is actually very high, right? $72,000 US. Right? So that makes us in the developed high income category by the World Bank, right? And then when you look at the population of children, so we're about 6 million. Actually, we have less than 800,000 children. So and the growth rate actually is dropping as well. I think last they said it was even less than 1. And so when you look at the head injury burden, right? So we are 2 of the children's emergency at the hospital where I work in, the Women and Children's Hospital. Actually, it's the largest of 2 public hospitals that provide 24/7 pediatric emergency services. So we are actually somewhere in the middle of the island. And so actually a lot of parents will just bring their children when they have head injuries, and these are very minor head injuries. It could be fall, or they had a fall and vomiting and so forth. So majority of the head injuries are seen here. I mean, there are also private doctors and also general practitioners who do see, but many of them will actually refer the patient back to the emergency as well. So we do see quite a lot. And so there is a management protocol that the children's emergency doctors do. So they take the history, examination, then you classify the degree of whether it's severe or minor, right? And then also looking at, they may do some skull x-rays, but it's not something that they do unless patient has got a big scalp hematoma or a facial injury, all right? And then actually the admission will depend on, what the criteria is, and I'll show that to you after this. And some of them may need a CT scan of the head, although many of the children do not really need them. So then the question is whether to admit the patient or not. And when they are admitted, then they are admitted to the neurosurgical unit. So if you look at the, the criteria they use, I think the clinical side, it's quite, you know, on the, on your left, it's actually quite, also on your right. It's what we would say is indications. But you look at the one on the left, the history, a loss of consciousness of 1 minute, right? The question actually you never know is actually what do they define by loss of consciousness. But the things are like, for instance, 3 discrete vomiting episodes. Now, I can tell you that actually a lot of children vomit, and then what actually happens is that they're vomiting, then they get a history that this patient actually knocked the head 3 days ago. Okay, so this patient is admitted as a head injury vomiting. And many times you find that actually what they have is just a gastroenteritis, right? The history of head injury is taken, but it's not really thrown. And so then the other one that actually you look at that's quite, it's actually any child actually less than 2 years old. In fact, there's a cutoff. Anybody less than 6 months, you come to the emergency with a head injury, minor, because actually a lot of our children, the parents, they like to sleep with the children. So the child will sleep with the parent on their bed. And then, you know, parents get out, the child rolls, then poof, they're on the floor, right? Now, as long as they're less than 6 months old, automatic admission, even though neurologically they're all well. So the admission criteria actually is quite low. Now, if you look at the number, I couldn't get the numbers from the A&E, but the last 2 years, they see about 3,000 plus so-called head injuries, and then about 1/4 to a third are actually admitted. And then when you look at the actual number of neurosurgical procedures that are done, actually it's very, very small. So this would be craniotomies for head injuries, or even just the insertion of intraventricular ICP monitoring pressure and so forth, right? Of course, we also have a small number of non-accident injury cases, but the actual number of surgeries done per year, actually for severe head injury, is actually very small. So the question is, are we admitting too many mild head injury patients? Right? So as I mentioned, about 25-30% of the 3,000 plus cases seen annually are admitted. So our admission guidelines to relax. So as I mentioned, you know, head injury, vomiting could be actually the upper respiratory tract infection, gastroenteritis in a child, which is much, much more common than actually the, you know, problems related to head injury. But these children will be admitted under neurosurgery, all right? And of course, the age of the child and so forth. So the thing is, this in a developed country, this is probably not unexpected. I think parents are much more well-educated. Their expectations are very high, and they want to make sure that the child is seen and nothing is going to happen. And so we define the child as having a mild head injury based on our own criteria, GCS 15 or less than 14, right? But to the parents, any knock, any short loss of consciousness, any post-traumatic seizure, it's serious, right? So parents want the best for their children. So, and as what our earlier Dr. Singh mentioned, I mean, there are actually so much expectations, and our doctors do also have a fear of being complained against, or, you know, usually not, but can even be sued if you have a serious injury that has been missed. And of course, the cost of hospitalization in many developed countries is high. In Singapore, it's not as bad. I know that in the US, you know, you rather do a CT scan and discharge the patient than actually admit the patient for observation. But in our case, the cost actually is not that high. And actually, even if they need a CT scan, they will be admitted, right? And we have insurance schemes as well. So again, you know, the cost is not so bad. And the other thing, of course, is our families, usually husband and wife, father, mother, are working. Right? They're working adults. In fact, most of the emergencies come after 7 o'clock, because that's when parents go home. They found that, oh, something happened to the child. And because they do have live-in workers or grandparents looking after. Okay, so yeah, something happened. Boom. Because it's late, there's no GP, they'll just come to the emergency department. And they'll rather have their children being observed in hospital rather than to go do it at home. But there's also another perspective, right? So as neurosurgical doctors looking after all these admissions, right, these are all bread and butter cases. And of course, we don't do CT just to exclude admission. But actually, from a profit and loss economic perspective, actually, the admission of a child for observation of minor head injury is actually a profitable proposition, right? Because they just look after, you don't do any CT scan, you don't do anything, next day you just review them, okay, go home, and that's it. So those number of admissions, I think, help to so-called support the other causes of neurosurgical care, that tumors, the severe injuries, and so forth, that actually cost the hospital a lot and actually make the hospital lose money. So this is like the other side that helps us to keep us in the black. So then, talking about concussion, so I think we all know what concussion is: a biomedical injury resulting in an alteration in the brain, all right, direct blow to the head of the body, all right, and there's also this pediatric post-concussion syndrome that was mentioned many years ago. People don't seem to do it, but there was any child with injury to the head, there's a brief alteration of consciousness, and then it's accompanied by a flaccid motor state, right? Then they recover completely, right? But in between, there may be a brief period of vomiting, pallor, anemia, right? And it's thought to be the lower end. And we do see that once in a while. Right? But I think the bigger one, actually what we're talking about is the symptoms that are created. And most of these are sports-related, creation-related concussions, concussions resulting from falls and road injuries, right? And then these patients may present headache, memory loss, difficulty concentrating, emotional changes, nausea, vomiting after the injury. Right? And of course, the sports people have taken up this because it's much more common, and of course, they have now to be very careful after this post-traumatic encephalopathy was mentioned, and they do see that. So, in fact, they are the ones that are actually making the definition and putting in a lot of the work that's going to be done to look after this, all right? So we know it's not direct blow to the head, typically short period of loss of consciousness, and then impaired neurological function, right? And so they seem to recover, right? And so there may be some neuropathological changes, but actually the symptoms reflect functional disturbance rather than structural injury. Although when we talk about NAI, it's what we can see on the scan and what we cannot see, right? So this range of symptoms. And there was actually a definition of persistent post-concussive symptoms, right, which last more than 4 weeks in children based on the consensus statement on concussion in sports. So we use that. So this is the definition of what we can do, right? So the symptoms are actually somatic, cognitive, emotional, then there may be physical signs, there may be balance impairments, behavioral changes, cognitive impairment, and then sleep-wake disturbances. Okay, so these are the things that you will look out for. And basically what happened is, so these are the at-risk groups, also if a head injury, minor injuries, athletes, and so repeated injuries. Right, so that we actually again have a care path for this. So we're looking at what to do on discharge. Basically, it's just to make a baseline assessment of cognition, arrange follow-up by physiotherapists because of the symptoms that we talked about earlier, and then we have an outpatient concussion clinic. And so this is a baseline cognitive assessment that is being used in the children's emergency, although I understand they don't do it all the time. Right? And then the patient is discharged, they are given a pamphlet on consultative advice, early appointment to see the physiotherapist outpatient, and then review next concussion clinic. And so one of the things, of course, is very important is ensure adequate rest. And I put that in red, limited screen time, because today all our children are spending a lot of time looking at iPads and computers and things like that, their phones. So this is one of the areas where I think can make this type of injury worse. Right? Then timely return to school. Right? And there's certain level activities that the physio may actually advise. So then, but we also have cases that are admitted for the ward, but most of them, again, may not actually need much. We may do a CT scan or MRI depending on, the age of the child. And then, but in the ward, the physiotherapists will review them, and then, of course, they're given education on management. Right, so we started the concussion clinic. This is Dr. Koh, who actually runs the service for us, because I find that they're asking me to sit in a concussion clinic, I get concussed at the end of the... so they come from various aspects, and it's run once every 2 weeks, and they will actually have to ask to fill what is called a PCSS form. So this is the form that actually looks at post-concussion syndromes based on the post-concussion syndrome skills, and to actually measure severity and record symptoms, right? And then after that, patients are divided into 2 groups, the so-called concussion symptom group, with CS, which actually they recover within 4 weeks, and then those who do not recover after 4 weeks, right? And so they actually have the same management strategy, physiotherapy review, exercise recovery program, and then education on symptoms and academic accommodation, and then if necessary, referral to other doctors for medical issues and symptoms like vertigo, headache, learning difficulties. So just looking at the clinic, what we have seen in the last about 30 months, right, looking at some of the data that was presented, I just give you a very brief summary. So basically we had 139 patients aged 5 to 17, and most of them had post-concussion syndromes, and there was about the same ratio of male to female, right? And actually looking at, it was much more prevalent in the teenage groups, so those about 13 to 18, then of course followed by the primary school groups. And the ones in the teenage groups tend to sustain head injury from sports, road traffic accidents, and assault. Right? The recovery, about almost 60% of them actually recover within 4 weeks, but most of them will recover by 3 months, and actually by 6 months, virtually everyone actually has recovered from the symptoms. Right? We lost some patients to follow-up, and basically, the most dominant concomitant symptoms were actually headache and giddiness, but then no strong association between the two. And we actually picked up that our female patients and teenagers are more likely to develop the persistent post-concussion syndrome. Right? So then the other thing is the concussion headache that we see. Right? It's one of the most common present symptoms, and commonly you just treat them with paracetamol, ibuprofen, but there is a small group that do not respond well, and then for this group, actually we give gabapentin, and about half of them found that actually it helped their symptoms. Then there are also associated conditions that could actually make the persistent post-concussion syndrome worse. So like for instance, if you had a psychiatric history, if you already had learning issues or past history of headache and concussion, you're more likely to actually have persistent post-concussion syndromes. So in conclusion then, as a developed country, Singapore, our emergency must see a large number of pediatric minor head injuries, and our admission criteria are actually quite loose in a way. So we are seeing more than probably what you will see in the types in a lower income country. And of course, we had this analysis of the patients with post-concussion syndrome, female, high impact injury, those who admitted likely more a history of psychiatric illness, learning difficulty, headaches, previous concussion, more likely to actually end up with persistent post-concussion syndrome. I mean, in my opinion, it's still a very nebulous subject, but the setup of the clinic to manage these children is definitely helpful to allow us to understand the peculiarities of our population. So I thank you very much for this. Thank you.
Yeah, may I ask a quick question?
Yes,
Thank you very much for an excellent talk. Quick question. Have you engaged the pediatricians or general practitioners in the area and educated them on how to manage concussion? And I ask because we had a tidal wave of concussion patients, usually sports-related concussions, coming into our emergency room, many of whom that did not need to be seen there, many of whom got unnecessary CT scans. And so we engaged on a collaborative project with our pediatric partners in the community to teach them which patients need to come and, more importantly, which patients don't. And frankly, it was quite effective. The number of ER visits really decreased tremendously, as well as the number of unnecessary CT scans. Right. You know, for reasons I don't understand, they are scared to manage children with concussions. And, you know, we just engaged them, gave them guidelines, who to refer, who not to refer. And I found that helpful and wonder if you've done the same and what your experience has been.
Yes and no, in the sense that actually, when it comes to concussion, a lot of general practitioners or even pediatricians in the private center, they don't want to deal with it. They actually send them straight to the children's emergency. Right. That's why we have this issue. But yes, you can see even in the emergency, the physicians there actually have worked out some sort of protocol, like who to admit and who not to admit. But then they will actually send them to our concussion clinic. As I mentioned, this concussion clinic is run by actually one of our resident physicians. She's actually trained in this pediatrics and also working together with our chief rehab physician and so forth. So actually there's a group that's actually interested, and they, this clinic started like 30 months ago. I think it's starting to grow. I think as I see it, we're actually going to have more sessions rather than less. But I think once we have a better understanding of the concussion that we see, in fact, what I'm reporting here is just a part of the paper that they want to actually send for publication in our local Singapore Medical Journal, so that these pediatricians and general practitioners will have access to the information and know what to do. So what I've reported is just a very small part of what they are going to publish.
Just quickly mention, we documented the effect of this program before and afterwards. We published in the Journal of Pediatrics, and we did have success. Success being measured in decreased number of referrals, decreased number of CT scans, and that's what we want to achieve. We don't want the numbers, we want those that really need our services.
No, so we actually don't do a lot of CT scan for these patients. Actually, generally now in our pediatric practice, we virtually don't do except when it's really necessary.
Right.
We tend to do MRIs, but those take a longer time and a longer period of time. So, and that may replace that, but they're not done. So as I mentioned, the cost of doing a CT scan is probably as expensive as actually observing the patient in our wards. So that's why they actually, a lot of admissions there. I mean, maybe things might change at some stage, might be too expensive, like what's in the US to admit patients, and then you might do something to make sure that these patients are better. Yeah.
Very good.
So again, very different ways of practice in different countries, you know. But, we can take what you are mentioning and then, put it and see whether it help or not. And I think for the other places, your countries will become high income very soon. And, you'll be facing with the same type of problems that we are dealing with. I still remember when many of the children that are admitted to I cannot imagine when I was a child, I would have been admitted if I had a head injury like that, probably be kept at home, and then really if something else bad happened, then only you send them to the hospital. But not the way it's practiced in our place. No, they all send them straight to hospital regardless of, and then decide what to do.
Perfect. Thank you so
much.
Thank you, Doctor. So, two quick questions now that we have opened the floor for discussion. One is, in one of your first slides on your algorithm for admitting patients, I didn't find any indication for CT scan for a GCS 15 patient, child with admission GCS of 15. What are the criteria for CT scan for a child with admission GCS of 15? Even if the child is very young, would you just send them home?
So actually, first of all, if the child, even if GCS 15 and if they are actually some symptomatic in some way, they will not be sent home. They'll be kept in hospital. Then we will make the decision whether we need to scan the patient or not.
Okay.
So it becomes a decision made by the neurosurgical team, not the emergency team. Because sometimes when the emergency team actually wants to do a scan, they will just do, but the patient will then be admitted to us. But there are patients that they admit, which they are not sure, and then we decide. Because many times, actually, what happens is, like I said, a child has persistent vomiting in the afternoon, evening. By the time he lands in hospital, actually, a lot of time the vomiting stops, and we don't really scan just because they're vomiting. I mean, if you look at a child, the fontanelle, if it's soft and all that, we don't want to do anything. And because I think we also have the obligation not to keep scanning young children because of the long-term risks of radiation exposure.
The next quick question is regarding the post-concussive syndrome, which you talked about. In the new study, the age ranged from 5 to 17 years. So my question is it possible? And if so, how would you evaluate concussion and post-concussive syndrome in a younger child, say a toddler?
So these forms actually, the form is there because it's created through that the conference. We just we interview the parents because the child may not be able to tell us. So in a way, the scores that are given for those age 7 to 12 may not represent what the child actually feels, but what the parents tell us, because that's the only way we can get information. But I mean, it still helps to know what's happening Because many times when you used to run clinics before, you ask parents questions, it's not a systematic. This form gives us a way to actually ask the questions much more systematically. That's all.
Thank you.
Thank you.
Thank you. Now, next we invite Dr. Peter Hutchinson from UK. He is speaking on global neurotrauma initiatives.
The ICRAM meeting in Jaipur. I'm going to give a presentation on global neurotrauma initiatives on behalf of my colleagues in Cambridge and beyond, particularly Tony Fagaji, who co-directs the NIHR Global Health Research Group on Acquired Brain and Spine Injuries, and my colleague Angelos Kolias. Trauma is a major burden. We estimate that approximately 11,000 people every day on this planet die from trauma, and about 90% of these deaths occur in low and middle income countries. And this is the map that Tony Fagaji has in his office. It sees the world as one could say perhaps the correct way up, because he likes seeing Africa and Asia at the top of the world. And I think that's very helpful because it does emphasize this major issue that we face. Of these 4 million global deaths, autopsies and other studies suggest that a substantial proportion of them is due to a traumatic brain injury. So there are a number of initiatives over the last few decades to try and improve the situation for these patients. The World Health Organization at the beginning of this decade launched their Action on Road Safety, and that is designed to reduce traffic-related deaths and injuries by at least 50% by 2030, and that's been adopted by the UN General Assembly. The motorsport governing body, FIA, have supported that with advocacy at the highest levels involving the motorsport community in campaigns and partnerships. And then there are more specific initiatives, including in India, the concept of free emergency clinical care for road traffic incidents occurring on some major highways, and an example in Bangladesh with road safety measures, engineering design, signing, marking, and even bridges over roads to protect people travelling to work. More specific investigator-led initiatives include Central and South America, so this is the NIH Fogarty initiative, again addressed to LMICs. And then we run the NIHR Global Health Research Group on Acquired Brain and Spine Injury, which aims to map, understand, innovate, and measure research capacity in TBI care. There are a number of colleagues globally who are involved in this work, and it's really important to appreciate the efforts that are ongoing. So people like Keep Hart from Harvard looking at the neurosurgical workforce requirements. We have Andres Rubiano, again, a lot of work going between him and Randy Chestnut in South America, managing head injuries in low-resource settings without ICP monitoring. And then many studies in India, and a lot of this has been led by our collaborator, Yogi Patisappu. The UK government commits 0.4% of GDP to what's called official development assistance funding. Much of that funding is now spent on healthcare and funneled through the National Institute for Health and Care Research. And we were fortunate in requiring the funding for this Global Health Research Group on Acquired Brain and Spine Injuries, supported by UK aid. The group initially focused on traumatic brain injury, but now has an ethos of trying to improve the care management and outcome of patients of a number of neurosurgical conditions across the globe in high, middle and low-income countries, now including traumatic spinal injury, stroke, brain infection relevant to neurosurgery, and CSF disorders and hydrocephalus across these four themes. Firstly, mapping care. Secondly, understanding care. Generating and implementing innovation, particularly cost-effective innovations. And I think theme 4 is important. This is how we build capacity, both in terms of clinical service delivery, but also research. In order to get a hold for this problem, we performed the GENOS study. So this was a snapshot study of emergency neurosurgery for traumatic brain injury. Any hospital in the world receiving patients requiring surgery for head injuries were eligible to join, and this was led by my colleague David Clark and published in the Lancet Neurology in 2022. What we looked at is we mapped countries according to the Human Development Index, very high, high, medium and low. There were over 1,600 patients recruited from 159 hospitals in 57 countries. The overall mortality was 18%. Interestingly, it was highest in some of the medium developed countries and low, but actually the very, very low, the mortality was lower. And I think that raised a concern that there's possibly many patients who are dying because they don't have access to care. The mechanism of injury and traumatic brain injury varies according to country. The epidemiology of this condition has changed in high-income countries. We now see fewer patients in road traffic accidents. This has become a disease of the elderly, people falling, often on antiplatelets and anticoagulants. So fall is now the commonest mechanism of injury in many countries, but sadly road traffic collisions remain prevalent and an enormous problem across many parts of the world. What's quite shocking is the median time from injury to surgery for these patients. That was 13 hours, and that was really across the board. Even in the developed high-income countries, there were major delays to surgery, and if we're going to try and address that, we really do need to get that figure down. The commonest operation in high-income countries is a craniotomy for a supratentorial acute subdural hematoma. In other countries, it is extradural hematoma, epidural hematoma, or elevation of depressed skull fractures. But what the study identified is the issues in terms of access to care, delays to surgery, lack of access to CT scanning, I'll come back to that, intensive care, ICP monitoring and rehabilitation. And I think what this highlights is we need a systems-wide approach to improving TBI care globally. The guidelines that have come out to date are very much focused on high-resource settings, and it's important that we develop sensible guidelines tailored to the resources available. Some of the other aspects of the group's activities are to look and develop new technology. So we've already heard about infrared spectroscopy in this meeting. So we are working with the infrascanner to see how effective that is at detecting blood clots when CT scan is not available. And this does seem to be quite an effective instrument, particularly when significant blood clots are within 3 centimeters of the surface of the skull. So that we're undertaking studies in Colombia and Guatemala. We're also trialing it in Cambridge, and it does show great promise. The other concept is how do we follow patients up? For some of our randomized trials, we've of course relied on the postal service. That is deficient in many parts of the world. So we have now dissected out the Glasgow Outcome Score into an SMS text message. So this was designed because many people do have these mobile phones, not so much smartphones, but the Nokia brick phone is still widely available. This is something that we developed for use in Africa, but we now use this to follow up our patients in the UK. The initial group focused very much on medical issues, but what we've now doing is engaging nurses and other allied health professionals and getting involved in some of these projects, and also establishing a global health fellowship exchange program with ELMIC researchers where neurosurgical residents are going from the UK into different countries and a reciprocal exchange program back to the UK. As well as publishing, I think it's really important to look at impact and advocacy at all levels. As I've already said, guidelines need to be tailored to the setting and assisting national policy and partner countries. Service redesign at multiple sites, mentorship. But what we're really keen to do is a formal program of research capacity building. That is much more effective than going somewhere for a month, perhaps doing some surgery. But if we can help develop resource, that is probably much more powerful. And this is an example. My colleague Ricky Trivedi 10 years ago embarked on a program with Kajinga Sejija in Zambia, and we established a neurotrauma and subsequently neurosurgical course, and that has trained 6 more neurosurgeons, so there are now 8 consultant neurosurgeons in Zambia. As doctors, we understand clinical practice, we understand research, but I think what we're not good at is using our data to actually advocate and change health policy. There are specialists who can do that, and the health economists are experts. So the Royal College of Surgeons in London has now collaborated with the London School of Economics and Political Science to develop the Global Surgery Policy Unit. This, we are using the data to actually try and strengthen capacity development, advocacy and engagement, and encourage governments to spend more funding, healthcare, specifically surgery, and in our case, the management of neurosurgical conditions. So how do we go about that? So we now attend through the WFNS and the G4 Alliance, the World Health Assembly. So this is a meeting of all health ministers across the world. It's represented over 190 countries. There's been a number of initiatives, but what we're trying to do, and this is being led very much by Tariq Khan, is, as you know, many infectious diseases are notifiable. COVID was notifiable. If we really want to get a hold on the data, then we need to lobby and try and make neurotrauma a notifiable disease across the planet. That will provide the data so that we can lobby for resource to improve management. As a vehicle to assist with that, the group have developed the Global Neurotrauma Registry. This is called GOTBI. It is a platform that any hospital can contribute to. It is designed for people to put their local data on to assist with their own audit and change in practice, but also it will provide big national and international data to assist with some of the initiatives in terms of policy. So it's called GOTBI. If you're interested, please note the website or take a picture of the QR code. We're really keen to get as many hospitals as we can involved. There's now 756 patients in the registry. It started relatively recently across a number of countries, and we're particularly grateful to the contribution from India. And this is some of the data. So the commonest cause of injury in the registry is a parenchymal brain injury, and I think this emphasises the issues that road traffic accidents remain a very common and important cause. What else have we been able to do? So we have an interest in randomised trials. The NIHR initially focused on funding trials in the UK. There is a collaboration with the MRFF in Australia now, but beyond that, we're also looking at how we can develop and deliver randomised trials in low and middle-income countries settings. The Rescue Acute Subdural Trial, decompressive craniectomy versus craniotomy for acute subdural hematoma. By far the biggest recruit of that was India, and we're particularly grateful to NIMHANS in Bangalore for their contribution. And then we're running a trial of the management of seizures after traumatic brain injury. This is called MAST. MAST is 2 parts. It's a trial of prophylaxis, so a randomized 7-day course of phenytoin or Keppra used to seizure prophylaxis versus no drug for TBI patients, and also a study of duration where we randomize patients to the duration of anticonvulsant therapy following a seizure. And this is a trial that we're recruiting in the UK, but you can see on the right there we're beginning to struggle with recruitment, particularly in MAST duration, and therefore we're looking to collaborate again internationally, and we'd very much appreciate the engagement of Indian centres as we did in Rescue Acute Subdural. So if you're interested, then please do get in touch. So to conclude, I think it's widely recognised that the issues of improving prevention, advancing care and stimulating research, this is a big issue. There are good efforts, but they need to be strengthened and new efforts developed. I've talked very much about treatment, but clearly we need to do more on prevention, seatbelt legislation, helmets, etc. It's all very well writing papers in good journals and getting that sort of output, but that is not enough. We need to make sure that our research leads to impact and we transform this into policy and influence policy at local, national, international levels. And we feel very strongly that making neurotrauma as a notifiable disease would be a good way along the road. I'd like to thank many people who've been involved in our studies. globally. At the bottom there is a picture of the group launch in Cambridge, but there's just a few individuals that I'd like to point out. The collaboration with the WFNS has been really helpful, and Andrew Reisner is here, and David Adelson. Andres Rubriano conducting a number of studies with us, particularly in relation to the infrascanner and guidelines from Colombia. Our Italian colleagues, you can see Corrado Iacarino there, and Franco Cervide. Tony Fagagi from Cape Town co-directs the group, and much of this has been led from Cape Town, and we're very grateful to Tony. And then finally, our India colleagues. Some of the trials, I think, would not have happened without Indian colleagues, and particularly grateful to Indra Devi, Devla Shukla, and Matthew Joseph in Vellore. We've got a current database, and we're looking at some of the Vellore data. And finally, to Dr. Sinha, thank you very much for the invitation. Thank you for arranging the most fantastic ICRAM meeting, and I'm happy to take any questions. In September 2nd to the 5th, we are holding the International Neurotrauma Society meeting, neurotrauma2024.com, and you'd all be very welcome to come to that meeting. Thank you.
Thank you, Dr. Hutchinson. I think we have 5 minutes for discussion. Yes, please, Dr.
I've got questions for two of the speakers. Peter, there is so much bad global neurosurgery efforts. Silly surgical missions for procedures that aren't needed, and donation of equipment that isn't ever going to work. How do we harness those well-meaning efforts and the money that goes into them into sensible initiatives?
It's a key question, and we discussed this last night, and I think I tried to make the point that it's no good just going in there, doing some surgery and leaving. So, Mike. Okay. Can you hear me now? Yeah. Thanks, Kate, for the question. So, I think we've all recognised that these efforts have been laudable. People have tried to go in, they've tried to operate, put in equipment, and it's sort of fine while that mission is there, but then there's no succession planning and it falls apart. So I think the approach needs to be stepping back from that and taking this wider approach of trying to get groups together, either globally or specific initiatives in specific countries, to actually get people to firstly map what the need is and then try and build capacity. And the way we're doing that is through these courses. So I strongly believe that if you go in and deliver courses and training, both at the level of medicine, but particularly nursing and allied health professionals, but try and really penetrate into the health ministries and government is how to do it. There's still quite a long way to go.
I'd love to see some widely publicised guidelines of how to do global neurosurgery for people who are thinking that, what you need to do in advance.
So a lot of this, and I didn't have time, there's a professor of nursing in Derby in the UK called Charlie Whiffin, and she's taking a qualitative approach to this, because to quantify it and get the metrics is going to be very difficult, but a qualitative research initiative may work. But you're right, maybe we should work together on some guidelines in how to do this.
Even just things like, what's your engagement with the local health service? What do you know about the local disease patterns, etc.? It might make people think in advance. And then to Wan Chu, I love that he's making money out of minor head injuries, which is great at his hospital. But in adults, the world over, it's been shown that length of time in hospital, additional time in hospital, is dangerous. That unnecessary admissions, time in hospital leads to falls, medication errors, infections, worse outcome. Is that a problem in paediatrics? I mean, could these children be harmed by an unnecessary admission, or is that not a thing?
I think in general, anybody who is admitted to hospital will actually have, the fact that hospitals are not safe places to start with. The children that are actually admitted to our unit, they actually are admitted to the surgical unit, which in theory is a little bit safer than the pediatric ones, because there's a lot of upper respiratory tract infections and this GE and things like that. But not all because of a bed issue, right? Our surgical wards are actually full at times, and sometimes they will end up being lodged in the medical units. But generally, and actually I've seen a few kids that, initially the vomiting stopped, then when they come back to the clinic, mother tells me, oh, child went back, was good for 2 days, and then started vomiting, and they actually had brought the kid back to the ED, but because it was not thought to be okay, sent home, and so that kid actually had, caught a virus in the ward, and then, suffered. So it happens. But I think as far as we know, the actual numbers are not bad. Of course, we still have a bed issue that we try not to admit, but you see, we have no control over who admits, the emergency department. They want to admit, they will admit. What they've done since start of last year, I know that's why I didn't show any of the numbers, is that they now have what they call emergency department transitional ward, which they will keep some of the patients in there, right, which is a bit different from the major wards. And then, but the neurosurgery team has to go and review this patient for discharge. Not much different from actually being in a ward, but just in a slightly different transitional place. But then again, it's not a single, there are multiple beds, and you could have actually a child with GE being watched there as well. So the thing is, we actually have a role to make sure that our hospitals are as safe as possible, there are patient safety and all that sort of thing. But it is, as you say, a possibility that things can go bad if you have too many admissions. But yeah, generally, all hospitals now have a bed problem, right? And so I think the A&E doctors have to be much more, economically thinking in terms of actually to admit or not to admit.
Thanks.
Can I ask a question to Dr. Hutchinson? In your conclusion, you said that one of your conclusions that neurotrauma should be made a notifiable disease. Can you elaborate on that? How is it going to impact either the management or the prevention or the health policy?
Yeah, what we found is that data is very powerful, but you need to generate data and accurate data to get the numbers, both the numbers and the way that patients are treated. So the way to do that is to get people to put the data in. Now, in the UK, we have a trauma registry. It wasn't originally mandated. It was a voluntary. Then the funding, the hospital wasn't going to get paid unless they provided the data. So now all trauma in the UK is registered. We've created a platform, the GOTBI registry, globally for people to put in their data. But what we need to do is encourage people to do that beyond a voluntary basis. And if you can actually make these diseases notifiable, then they become mandated nationally, and then people have to provide the statistics and the data. Once we've got those numbers, we can go to governments, World Health Organization, and really try and get the funding directed. It's quite an ambitious plan, but it's a start. And I think what Kate was saying about going into places and operating, I think that's fine, but we need to operate, but we really need to advocate and penetrate into high levels of government.
Thank you. Taking the same question forward, the notifiability of head injuries in India still might be a difficult problem, because you have to understand we have got 1.5 to 2 million head injuries which are on record.
Yeah.
We don't know the mild head injuries. They're all grossly underreported. So to get that in place in a country like India with a 1.4 billion population is going to be a Herculean task. But yes, somebody has to start somewhere. So we have just got pockets where doing the work. So how to do that is going to be a difficult issue, which probably we have to deal with. We can't expect WHO or somebody else to do it for us.
Yeah, no, you're absolutely right. But the pilot data from the registry, GOTBI, I think we've had more buy-in from India than any other country to date, which is fantastic.
But the sheer numbers, actually.
the numbers need to grow, but we have to start from somewhere.
Yeah, yes,
but you're
true.
right. It's
That's
a challenge.
True.
It's a challenge.
That's true. And my question to my friend, Dr. Lokendra Singh, you put out these issues quite rightly. I just want to share the way I deal with things. If you speak to the just immediate blood members after a serious problem in neurosurgery, trauma, they don't absorb anything. The mother, wife, the brother, father, son, they are in so emotional state, they don't absorb anything. So my policy is that whenever a situation comes like that, unlike UK where you are just supposed to keep the confidentiality of the patient and just talk to the blood relation, I do the opposite, which is allowed in India. I said, how many people are with you? And there are some 10 neighbors or 15 friends. I said, please bring all of them together. So you speak, give a lecture with the images and tell them this is the situation. And the neighbors and the friends would absorb better what you say than the emotionally run down family members. And then you repeat the same thing after 2 days, after 3 days.
Please,
and
please,
that's
please,
where
thank
the message gradually gets seeped in, because you don't have the message going through your ears in the very first moment. So that's probably one way I feel. And the last thing I do, very, very confidently tell them, this is my opinion, this is what should be done. You are encouraged to take n number of opinions from anywhere you want. I would allow that. I would be very happy if any of my colleagues gives anything more on this aspect. I'll definitely appreciate that. By doing this method, I find all these things just die away. There are agitations initially. They feel that, they are wasting money, they are wasting time, nothing is being done. But the very fact that they don't understand anything. And some of the Google educated people, they want a number. And I use the crash scoring system. And I give a printout that this is the thing, this is the on record that we can tell you the chances of your survival and outcome after 6 months. So by doing all that, I spent a lot of time on that. And the first appearance would be a long appearance for 45 minutes or 1 hour. It doesn't matter. But that makes the thing very, very simple for you in the subsequent period.
That's absolutely well taken, and that's true. Actually, as I said, the near and dear ones are totally, they are in extraordinary situations. So their wisdom is gone.
Gone, yes.
So they're totally on basic instincts.
They're lost.
Yeah. And actually in a group. That's why I said, you should study the group. So suppose there are 10, 12 people are there. 3, 4 faces you will see who are not much affected. They're still composed. And they maintain the stoic state. So there will be few on the periphery of the group.
Yes.
So I think you should catch them and try to understand, make them understand, and they will understand the group.
Yes.
They will make them understand.
Yes.
So it does work.
And the last thing I say is that I don't want any phone calls. That's the tradition in India. Some DIG or minister will try to ring up. I said, sorry. Then I use the word patient confidentiality. So I don't know who is on the other side of the phone. I won't entertain any phone calls. Please come and meet me 100 times. I don't mind. But I won't encourage a single phone call. So some of the things I try to do to avoid all this confusion. Because the phone call comes, you say something, the man carries something. So these bizarre things which happen in India is something to be managed.
It's often recorded. When they call you, they record they record and they can selectively play it again.
Yes.
And what you do, calling all the relatives, is what I also do.
Yes.
Because I ask them,
it's not the relatives.
whomsoever, relatives, friends, whomsoever is outside, all the group is called.
Yes.
And when I am counseling them, it is the CCTV camera is recording everything. CCTV camera is recording everything. So that's one thing. But I think we are running short of time, so it's need to close the session. We had a very interesting 3 lectures and a lot of discussion, so we'll have to close the session. Thank you. Thank you all the delegates, and thank you my co-chairpersons.
Thank you.
Thank you, chairpersons. Before we go for a tea break, I have an announcement to make, please. Feedback forms will be sent on your emails regarding the workshop organized on the 29th. All the participants are requested to please fill and submit the forms. Vivek Kumar Ved, Additional Director and Senior Consultant, Department of Minimal Access Neurosurgery and Neurointervention, Fortis Escorts Hospital, and Dr. David Edelson, Professor, Department of Neurosurgery, West Virginia University.
Good morning. The first speaker today is Dr. David Edelson. He is Steve A. Anthony Endowed Chair of Children's Neurosciences, works there. He is Vice Chairman for Rockefeller Neuroscience Institute, Executive Director, WVU Children's Neuroscience Center, Professor, Department of Neurosurgery, and at West Virginia University. He will be speaking on decompressive cardiacity in children.
Well, good morning. Sorry, I didn't realize I was a chairperson for this one. But Thank you, and VK, thanks for the surprise. It's okay. And it's just so wonderful to be here, and what a fantastic meeting. Real congratulations to you and all the organizers for this wonderful meeting. And it's been just absolutely wonderful visit. So just as a reminder, especially with regards to children, unfortunately, trauma and particularly traumatic brain injury still remain a leading cause for death and disability for children, and in many instances more so than any other and all other pediatric diseases combined. The problem is our management has been very limited with regards to the management in children because there's been very, very few institutional trials, and particularly very few studies that really look comprehensively at some of the issues with regards to children. And while some of the evidence base and guidelines have been quite helpful, I would argue that we still need a lot of work in order to develop these particular areas. Obviously, many of you are familiar that the early history of decompressive craniectomy showed no real clear improvement, but really with improved experience and particularly trials such as that by Peter Hutchinson and others, we now know that indeed that this therapy is much more widely utilized and has a potential for improved outcome. But the questions remain, unfortunately, with regards to children, what's the best approach in these children? Got it. So I just wanted to show this case, and this is a 15-year-old who was hit by a car while on a skateboard. He came in initially a GCS of 8, but then deteriorated. You can see the external ventricular drain that was placed in this particular instance, but you can see how tight the brain is in this patient. Unfortunately, ICPs went up, and so this was the decompression that we did. We did a bifrontal, and you can see the swelling outside of the skull. And in this case, I do want to say that this was my first decompressive craniectomy as a faculty member, so I would even, in looking now and criticizing myself, I could have done it a little bit bigger. But this child actually did well, and this is his CT about a month later. He went off to rehab. He came back about a month later, got his cranioplasty and bone put back, and in this instance, this child did really quite well, and we were very pleased. But again, what guides that treatment, and also really what is the outcomes for these patients? So while you may have one patient like this who does well, there are numerous others that we can refer to who don't do as well. Well, there have been a number of pediatric guidelines that have been put out, initially the ones in 2003, and then the compendium ones that came on in 12 and 19. Really, it were served to compare to the adult guidelines, but really with a focus on children. And with the most recent edition in March of 2019, so now actually 5 years ago, what it did was to sort of redirect how we do clinical guidelines. And so this was an instance where we did indeed create a consensus and a synthesis of those guidelines in order to put together a clinical algorithm, so to try to make the guidelines useful. But, and I won't belabor these, but suffice it to say is that surgical intervention was noted for when, even early on, if there was some concern about impending herniation. And then similarly as a second-tier therapy, if indeed there was intracranial hypertension refractory to medical therapy. Well, I won't belabor, the different types of decompressive craniectomy, so primary versus secondary. We're now starting to see the differences in their application. And I think that when it comes to children, unfortunately, we still really have a lot of questions that need to be answered. So while some of the information has come forward with, from the adult side with really great studies by Peter Hutchinson and others, I think, though, that with regards to children, we don't have comparable studies yet. But I would at least refer to the guidelines. While the literature is still inconclusive, we do have a lot of factors that we still need to take into consideration for each individual patient. Obviously, safety being one, the concept of whether what we're trying to achieve, which may be reduce or control intracranial hypertension and improve perfusion. And then ultimately, we'd like to know, what is the impact of this surgical intervention on outcome? But the data is lacking. So what are the indications? What would be the optimal mechanisms or pathologies in which we should be doing the decompression? What types of decompression should we do? There's such variability, and again, this ends up is what causes some of the issues in the literature and the conflict that we see. And then the timing, should we be doing early decompression versus later decompression? And then ultimately, it's about the repair and reconstruction. So suffice it to say, I would argue that at least at present, the goals of surgery are to lower intracranial pressure. So whether it be medically intractable intracranial hypertension and prevent herniation, or secondarily to remove a mass lesion when there is a particular concern of intracranial hypertension, leaving the bone out at that time. Clearly, if we can improve the perfusion of the injured brain, so as I mentioned previously, we want to create a milieu for recovery and for healing. Then hopefully we can reduce the need for medical management, which has its own inherent problems. So when we make a patient super hypernatremic and as a result they start to get kidney problems, or we use pentabarb coma and they start to develop cardiac suppression and pulmonary issues, we need to balance the risk-benefit of decompression versus continued medical therapy. Well, the evidence base for decompressive craniectomy, as I mentioned, is really for the most part been limited to the adult studies. And so, you're quite familiar with Peter's work in this regard. But I did want to highlight the fact that really we saw improvements in outcome really at about a year out from these patients. So while there wasn't really a significant difference really at the 6-month outcome, by 12 months, now we were starting to see some real differences between the groups. Unfortunately, we don't have this type of data in children, and I would argue with the developing brain that 1 year may even be too soon, and so we do need to consider potentially longer time points for the pediatric population. Well, at least at this point, with regards to the pediatric guidelines, there's very few studies. As I mentioned, there's only about 8 studies that met the inclusion criteria for the most recent guidelines. They were all weak class 3, so basically case series, and really didn't provide as much recommendations as we would have liked. But we do know that decompressive craniectomy may be effective in reversing early neurologic deterioration or herniation if done before the patient actually herniates. For the treatment of intracranial hypertension, especially when it's refractory to medical therapy, with a goal to try to improve outcomes and not lead to worsened medical secondary effects. And when the evidence for decompression alone, right now, it's insufficient for us to say that it does improve outcomes. So if you review the guidelines, this is kind of what it says. There was no level 1 or 2 recommendations for decompressive craniectomy. It's suggested for treatment of neurologic deterioration, herniation, or intracranial hypertension refractory to medical therapy. So the question is it effective in lowering ICP? Well, unfortunately, when you review the literature, there is wide variability. There's variability in what's considered pediatric, what were the indications, so primary versus secondary, the types of surgery that were used, unilateral versus bilateral, duroplasty or no duroplasty. There are even some case reports and use of ligation of the superior sagittal sinus anteriorly and sectioning the fornix. And then, of course, variability in the outcomes that are reported. But ultimately, I would say that with that variability, it often becomes pathology dependent rather than surgeon dependent. And as I alluded to in a couple of days ago, I think we need to take a much more precision, individual approach to these patients. And so these type of questions really do need to be answered in the future. With regards to cranioplasty, Corrado, was really led this effort, and I would refer you to this article that's now about 3 years old. But it just talked about in the pediatric chapters that autologous bone was preferred. If it wasn't available due to disposal or contamination, osteoconductive material would be then the preferred. And then if they were older than 3, synthetic material could be used. With regards to timing, again, systemic neurologic and wound conditions must be stable prior to cranioplasty, but the optimal timing and recent neuroimaging, again, unfortunately, still remains to be seen. So I say these and go over these in summary is really that there are so many questions and key issues that we need to answer. And I think this is really a call to all those young people out there that we have lots of research questions that can be answered, particularly in this area of surgical decompression. These are just some of those questions for decompression, and similarly the same type of issue with regards to questions that we have for cranioplasty and reconstruction. So in conclusion, I think our literature does support decompression for lowering ICP, but not for improving outcome, at least at this time. The evidence is lacking, but I would argue that we need that evidence. And similarly for repair and reconstruction, optimally we want to use autograft or osteoconductive materials for patients, but the timing and et cetera still needs to be studied. But I think this again is on an individual by individual basis. And so I thank you again, VK, for this invitation and the opportunity to be here with all of you.
Thanks, Dr. David. Now I invite Professor Moni Vanilla, who is the president of the Israeli Neurosurgical Society and is head of the pediatric neurosurgery unit. He is also an ethical researcher. He works at Rambam Healthcare Campus and Technion Israel Institute of Technology, Haifa, Israel. He will be speaking on management of complex traumatic brain injury syndrome.
Thanks.
Well, by the time the presentation is up, first of all, I want to thank you. Thank you very much for inviting me. I'm so happy to be here. It's a great meeting. It's a great city. I enjoyed it, and for sure I will be back in the future. I feel a little bit, should be humble to present after David, and there is so many question marks in your presentation, and I can assure you that there are more question marks in my presentation. I will start with a case illustration to speak about how to manage a complex traumatic brain injury. So it's a 6-year-old boy that was hit by a missile ricochet that was fell near his house, and the ricochet went into his skull. And as you can see, the ricochet moved from the anterior or frontal area of the left hemisphere and stuck in the falx, the posterior falx, and bone fragments just broke and went tangentially through the left hemisphere. So when he arrived at the hospital 15 minutes after the injury, brain was already out of the skull, out of the skin. We took him to surgery. Actually, in 1 hour, he was in the OR, underwent craniectomy, debridement. During the surgery, he went into DIC with hemorrhagic shock, so we couldn't insert ICP monitoring, just tried to control the bleeding, and took him to the PICU. In the PQ, he was stabilized from the hemodynamic, in the hemodynamic system, received plasma to normalize the coagulation factor, and as soon as we could, we put the ICP in. He was heavy sedated, receiving hypertonic saline mannitol, and we kept CPP above 50, although his ICP was around 1450. When we saw that the ICP is still high, we took him to another surgery to decompress the other side. We put him on cooling mattress, although questionable, but still we kept the CPP above 1560. Unfortunately, after the second surgery, the ICP only went up. Okay, so from 30 to 40, it went up to 50 to 60. So we performed another CAT scan, and we noted that the superior sagittal sinus is thrombosed. So we took him to another surgery, and this surgery, what we did, only an ectorectomy of the abnormal tissue on the left hemisphere. We put an EVD in. Until then, we couldn't put an EVD, and then we saw that the ICP is going down. Eventually, this is his last CT. He had staged cranioplasty after 3 and 6 months, and this is the child 4 months after the injury. So I just showed this complex case in order to speak about how to manage children with complex traumatic brain injury. So the first question is it the management is evidence-based medicine? So, well, you know, kind of, sort of, maybe, but not probably. So like in other fields in neurosurgery, we are lacking of evidence-based medicine in traumatic brain injury, especially in pediatric traumatic brain injury. So there are many guidelines, okay, in different papers, so people practice according to different guidelines, but there are consensus about few things. First of all, the need. So we for sure know that children are not small adults, okay, and the brain of a child is still developing and reconstructing. This is one thing. The other thing that we know that the compliance of a child's brain is better than an adult's brain. So sometimes we can see severe mass lesions without any clinical impact. And sometimes we know that it's a disadvantage, and sometimes it's an advantage because children can suffer more. And we also know that the most important thing is to try to prevent and to treat the secondary injury. But the secondary injury is composed from many components, pathophysiological and various mediators, cytological and others that we need to treat in order to stop or prevent the secondary injury. And of course, to save the penumbra around the dead tissue. So what are the treatment objectives? Again, is it still evidence-based medicine? So we know that we want to improve cerebral blood flow, and we want to decrease the metabolic need of the brain, and especially for the dead area of the brain, or to the penumbra in order to save the healthy tissue. But what ICP shall we use in children? Is it below 20, below 22, below 25? What is normal ICP in children? We don't know, okay? What is normal CPP in children? Above 50, 60, 70, how we measure CPP in children when when the blood pressure is different than in adults. We know that little children, their normal systolic pressure can be 40, 50, and will be perfectly normal. So what is the CPP of a small child with ICP of 20, 25? So we hardly have CPP. Shall we treat it? Shall we use ICP monitoring? So we don't know what are the normal ranges of CPP, what are the normal ranges of ICP. We know that we need to keep the venous drainage, so the heads should be in the midline. What about hyperventilation? When I started my residency, I hyperventilated to 25, and then to 29, then to 32, and then to 35. What about anticonvulsive? And I will speak about the anticonvulsive treatment later on in the next lecture. Barbiturate coma. unfortunately, or fortunately or unfortunately, we still see in some guidelines of adults no need in barbiturated coma. In some guidelines of children, barbiturated coma you can use a barbiturated coma. What about the modern modalities? Brain temperature biomarkers and electromarkers, as we call for the EEG changes? Well, what we should know, that there is a very important role to the nursing staff in all the things that surrounding. We know that keeping the head in the midline, 30 degrees, to avoid decubitus ulcer is improving the outcome of the children. So this is just well, it's not as nice as Dr. Adelson's slide, but it's some kind of protocol. And with regard to what to do with these children, the most important thing is to use a protocol. Know that you have a protocol. Know that your partners in PICU, the anesthesiologists, the nurses, know the protocol and following the protocol. And you should be in close contact with these physicians. The PICU physicians are the most important part, in my eyes, other than us, the neurosurgeons, that we are neurosurgeons, but they are the most important part of treating these children. As I mentioned, use a protocol, put the child in PICU, be in frequent touch with PICU. If you need to use EVD, it's better than CP monitoring. Don't hesitate to use CT scans, okay? We should expect the unexpected, and we should remember that children always surprise us. Thank you.
Before we move on to the next speaker, I would like to request Dr. K.K. Bansal, who's a senior consultant of Department of Neurosurgery, Narayan Hridayalaya, Jaipur, to please take his place as a chairperson of the section.
On postoperative cerebral infarction after evacuation of traumatic epidural hematoma in children younger than 2, single center experience. Dr. Alfiki is a professor of neurosurgery at Cairo University in Egypt, member of the WFNS Neurotrauma Committee, former director of the Cairo University Emergency Hospital, and former director of the Cairo University Neurotrauma Unit. Dr. Alfiki, thank you.
Thank you. Professor Sena. Okay, good morning. First, I'd like to thank Professor Sena for allowing me to have to share our experience from Egypt in this wonderful meeting. And second, I'd like to thank you again for inviting me to visit India for the first time and to know how generous and hospitable are the Indian people. So before I start to talk about the effect of extradural hematoma in infants, I'd like to first introduce my university, which is the largest university in Egypt, which lies in Cairo downtown with a capacity of 4,500 bed capacity. And our neurosurgical department have like 185 beds with more than 55 beds only for neurotrauma and emergency. We have like 18 beds for ICU, for trauma only. So as we know that traumatic extradural hematoma account for 2 to 3% of head injuries in pediatric population, and this traumatic extradural hematoma is a life-threatening condition, especially in infants. Although it is not common, traumatic extradural hematoma may be encountered in tertiary hospitals because of lack of that service around. We published our experience in treating patients in young age below 2 years in 2023, December. So why infants are unique? Because as mentioned before, they have different clinical presentation and they have non-specific clinical presentation like poor crying, decreased activity, which may be missed by the family. And this is the most important issues to increase the awareness of the family about that kind of presentation. And because of the patient, the infant cannot communicate, which make it difficult more to pick up the change in his life pattern. And because the dura is easily strippable, so it can allow, like mentioned, that large amount of hematoma can be present with no symptom. And the infant, as mentioned also, have high compliance of the cranial vault and the brain, which account for decreased intracranial pressure, although it will take a long time to present with high intracranial pressure. And although 50% of infants with extradural hematoma having anemia during presentation, they have a little amount develop ischemic complications. So we retrospectively examined the data for 28 infants operated for extradural hematoma in our institute from December 2016 to February 2019 for about 26 months. And the infant with associated subdural hematoma and contusions were excluded, plus, of course, the patient who did not need intervention. And the variables we collected, including the gender, the age, the mode of trauma, the clinical presentation, and the preoperative GCS, and the location of extradural hematoma, whether temporal, frontal, the neurological deficit, if it is present on admission or not, and the preoperative hemoglobin level, which is an important factor, and the volume of hematoma, and the basal cistern, whether it is closed, open, compressed, and the midline shift, and the timing from trauma to surgery, which is a critical finding. So this slide presents a sign of hyperacute bleeding. As we can see, there is double density in the extradural hematoma, and there is midline shift. And as I mentioned before, cases like this may present late, and this will be the problem for developing postoperative infarction. This is another case. As we can see here, there is a large hematoma, and there is underlying edema, which means that this hemisphere is compressed in comparison to the other side, which have some sort still of subdural fluid. So we found that only 7 cases of these infants developed infarction. And interestingly enough, these are the factors that was linked to that infarction development. The poor presentation when the patient came to our hospital below 9 GCS was linked to that, and the presence of neurological deficits, either epilepsy or weakness, was linked to development of this infarction. The huge size, and we defined that by being hematoma more than 100 millimeter, and the timing between trauma and surgery. And this is the most important factor that we found, because most of cases, as I mentioned, they have delayed presentation due to awareness of the family. So the time when it was more than 6 hours, it was linked to these 7 cases of development of infarction. The midline shift more than 50 millimeter, and of course, compression of the basal cistern will increase the intracranial pressure. And interestingly, we didn't find any relation between the age, whether it is below 1 year or between 1 and 2 years, related to that infarction development, or the mode of trauma, either fall or accident, or the location of the hematoma. We were expecting that it may be related to the temporal loop, because we are expecting more if they have a large hematoma to have some sort of conization, but interestingly it was not. And of course, like what we said before, the hematoma, if it is associated with anemia, it was not linked also with the development of infarction. So these are some of the tips that should be taken in consideration, is to be done by senior resident and senior experienced anesthesiologist to avoid hypothermia, which can cause cardiac arrest in this young age. And because of limitation in some hospitals in low and middle income countries, we have to switch off the air condition because it makes the patient more hypothermic, because sometimes you don't have that control for that air condition inside the room itself, and you have to contact the administration to do it, which will take some time. So we do it as a preparation to stop it during the time of surgery. And we use enough wrapping for the infant for the exposed part, and if we have, of course, the air warming system, we can use it. The use of wide access IV line is important. Even if we can do CVB insertion, this will facilitate that we are giving blood during the operation. And rapid correction should not delay the surgery. It can be started while we are in the OR. And because of the hemodynamic instability, which may need some post-operative ICU or to stay in the intermediate care. Some of the bleeding may occur even post-operative because if we use a suction drain, it may suck more blood. So we have to revise and do post-operative hemoglobin to check if the patient needs or not. One of the important points is to how to avoid bleeding during the scalp opening, and we usually do it step by step, not to open the whole scalp, just to drip a lot of blood. And we use also the dissection scissor to do the craniotomy instead of craniotome, which may not available in many of the hospitals in low-income countries. So we just open with the craniotome or the manual drill, just opening and use that dissecting scissor to open. This is an important tip because of the large size of the hematoma, so we are expecting that there is a large defect post-operative because the brain will take some time to regain to its normal position. So we are using the central tuck-up suture by opening in the center of the bone flap to tuck up the suture of the dura to elevate it. As we can see here, the development of this post-operative infarction, but the preoperative image also show that there is infarction preoperative. So to conclude, although it is not common in the literature, traumatic extradural hematoma in infant may be seen in tertiary center like our center, and traumatic extradural is a reversible pathology, of course, so we have to have most of the cases to be operated upon, and the experience of the neurosurgeon and anesthesia is an important factor for success of these cases and avoiding the post-operative conclusion. And the most important factor in our research was the timing between the presentation and the trauma itself and the surgery. The cutoff value was more than 6 hours, so we expect that awareness to the family about the pattern of the trauma and how to pick up a new signs to go to hospital is important for these cases. So thank you, and you are welcome to invited to be in Egypt. Thank you. Okay. Thank you.
Any questions from the audience? No? Oh, no. Okay, and the last. So the next speaker is Dr. Girish Solanki from UK. He is going to speak on traumatic brain injury and indices of multiple deprivation. Dr. Girish.
Thank you, Mr. Chairman and colleagues. It's a great pleasure to be here amongst friends. And I've taken Sandeep's section because he wasn't here. I was actually going to give the talk on the other section, but it's a pleasure to be here. And I wanted to thank for the opportunity to talk about the work we've been doing on traumatic brain injury, pediatric traumatic brain injury. There's a different type of visualization. So normally we look at traumatic brain injury based on severity scores, looking at CT scans. But what I thought is, now that we're entering the date of the time of artificial intelligence, machine learning, and other things, we started looking at how do we look at who is suffering from traumatic brain injury, and does traumatic brain injury differ from the socioeconomic class of people? So, you know the introduction, my previous colleagues have done a great job on this, so I won't spend too much time, but of course head injuries can be a result of falls, road traffic accidents, non-accidental head injuries in children, and of course all of that requires admission and assessment at the emergency department. In the West Midlands where I work, children under the age of 15 account for only about 15% of the admissions. Males, of course, predominate with 15%, and females a little bit less, 8%. And interestingly, the commonest injury for us is falls, which account for 2/3 of the admissions in boys and about 40% in girls. So when we think about, parents will only take children to the hospital unless they absolutely cannot avoid it. So every attendance to any department by a parent bringing the child is an important attendance, and is a significant event in the family's life as well. So we wanted to see how does this traumatic brain injury differ in different families? And we looked for how do we demonstrate it, and then what are the sort of preventive measures that we can apply once we know that relationship. So in England, fortunately, there's something called IMD. It's a singular score, so it's a number. It's an index of multiple deprivation, that's the acronym. It combines a number of indicators, economic, social, housing issues, and it gives a single deprivation score of individual neighborhoods, which are called the lower super output areas, so LSOS. And this is a population of about 1,000 people, up to 1,500 people. So basically, they know exactly where you live and which building, what's the LSOA score, and they can tell whether you are living in a deprived area or in an affluent area. So that data is public data. You can access it by just applying for it to the government, and then you can use that to run out statistical analysis to your own patient data. So the range 1 is the most deprived, 5 is the least deprived groups. So when you look at the score components, the domain weighting tells you that if you have income deprivation, so income, employment loss, or health deprivation and disability pretty much account for nearly half the score. And if you add health deprivation, education, skills, and training, that's 3/4 of the score. And then there are other things like barriers to housing and services, crime, disorder, language, living environment. So all of that accounts for just over 1/4 of the score. And the total number then arrives based on those divisions. So we got, being the sort of the tertiary level center, we got a trauma research network which collects data for every patient that comes to any department. So we looked at a sample over 5 years of 100,000 patients, where just 12,268 patients were head injuries. Of those, 78%, were trauma. Of those, 9,500 were head injuries, which is about 78% as a result of falls. So when we looked at this, of course, the ratio was again 2:1 for boys, and the range was from 3 months to 15 years. And this, as I said, is a sample of data for 5 years, all A&E departments that were collected with the standards of demographic data, geographic data, and then we looked at the head and systemic injury severity, and then we applied that against the indices of multiple deprivation in the West Midlands, and then carried out the statistical analysis. So just briefly tell you the results. So first, looking at gender, what we found is that the male-female ratio is about 1.8, and pretty much all of the indices. So remember, 1 is the most deprived group, 5 is the least deprived group. So 5 is the most affluent, 1 is the poorest. And in pretty much all the groups, you could see that boys are more affected. When we look at the emergency admissions to the index, again, there's an overwhelming large sort of section in the group 1, which is the most deprived group, which accounted for nearly more than 80% of admissions. And when we look at falls, again, you can clearly see that boys overwhelmingly more affected, but particularly in the group 1, which is the most deprived group. And then when we look at severity of injury against the index, and looking at severity, you can see from left to right is the contusion of the body, a mild head injury, a moderate and severe. In all of those groups, group 1, which is the most deprived group, overwhelmingly numbers its presence in all of the groups. And then when we look at statistically, looking for observed and expected values, the first group, the most deprived group, had significantly more observed cases than expected. And if you put this in a tabular form, now what you can see quite glaringly is that the least deprived group that hardly had any head injuries from falls. So in fact, it's 0. We didn't count a single fall in the least deprived regions suffering severe head injury. So that kind of tells you that there is a relationship here. And then we also found a previous publication on pediatric minor head injuries, not severe, minor, and the comparisons were glaringly similar to our findings. So for example, falls accounted for 62%, in our group was 64%. Head injuries rising 77%, age 0 to 5. So the younger children had more. Most of the injuries were in-house. And again, you can say that the younger children, aged 0 to 3, they're usually dependent on the family to go out. So most of these injuries were at home. And those injuries, were clearly greater in the older children, in the 0 to 5-year-olds compared to the older children, statistically significant. And the children living in the most deprived areas were more likely to attend the emergency department with head injuries, again, a significant finding. So this is something that is being found again and again in our region. And I'm certain that this applies nationally as well. So what can we do? So the first thing, of course, protecting young children. So toddlers and young children they like to explore, climb, walk around, and dance. Now, the group 1 is where there is some socioeconomic deprivation. So often single mothers working, nobody at home looking after the children, or there is an older sibling looking after the children. And if their housing, of course, is also poor housing, so they may not have the ascribed sort of regulatory safety in the house, so the windows may not be protected. So it's very easy in the summer, for example, to open the windows, get some cool, and then the kids fall over those gaps. So you can help prevent injuries in many ways. Windows, of course, install window guards, simple things like don't place your furniture, chairs close to windows so the kids can't climb over. Make sure the windows are closed and locked securely. Furniture, again, avoid children climbing on furniture, particularly high furniture, beds. So all of this stuff is very, I don't mean to patronize anybody here, but it's the sort of stuff that when you go to any department, that's what you find. These are the things that are causing the children to fall. And a very simple preventive measure is to provide leaflets to the group 1 where these things can be brought to their attention. Often parents are teenagers, very young, have no experience, have not been counseled or mentored, and they struggle in a situation like that. Outdoor play, same thing at playgrounds, slides, monkey bars. This is where children fall and hurt themselves. Trampolines, significant number of trampolines. We recently published our experience on trampoline injuries, tricycles. So all of those things, simple advice that is known to everybody. And I would say for us neurosurgeons is sort of the thing that we should do to prevent those injuries by working with the emergency department and working on producing simple leaflets like this to distribute to those that attend any departments so that as a group they start becoming aware of what's causing those injuries and reduce them. So in conclusion, children from deprived areas are disproportionately represented in traumatic brain injury categories in all severity grades. Preventive and education initiatives for these groups and families may reduce frequency and severity of traumatic brain injury, and patients should be offered information on injury prevention during the emergency department attendance. Just wanted to thank everybody for helping us. The trauma network is a large network. We all quite seriously collect data, which then helps us do this sort of studies. Thank you very much.
Excellent, Mr. Professor. Our next speaker is Dr. Ashish Vidra. He's a professor at Department of Neuroanesthesiology and Clinical Care, All India Institute of Medical Sciences, New Delhi. She has a special interest in monitoring TBI, nutrition and TBI. She will be speaking on optimizing pediatric traumatic brain injuries outcomes, nutritional strategies in the ICU.
Hello, good afternoon, everyone. At the beginning, I would like to thank the organizing secretary of the conference, Dr. V.D. Sinha, and Shobha Purohit ma'am, for having confidence in me talking about this topic. So, our hospital is Jayaprakash Narayan Apex Trauma Center, All India Institute of Medical Sciences, with the total bed strength of 254 beds, with around 60 ICU beds, which are 40 of them are dedicated to neurotrauma, and 50,000 annual OPD patients. And less than 16 years, nearly we have 1,250 annual load with nearly 300 inpatients and nearly 150 to 75 ICU admissions. So generally when we talk about the outcome predictors in traumatic brain injury, we talk about mean arterial pressure and the intracranial pressure. A forgotten aspect is the nutrition, which is a main catabolic event and which surely affects the outcome, and all the data says that a patient who's well fed, is not malnourished, has a better outcome than the one who's malnourished. And the magnitude of problem is that nearly 1/3 of the patients, if they have a long hospital admission, they are malnourished, and the incidence is up to 78% and with ICU admissions. And they corresponds to prolonged hospital stays, mechanical ventilation, increased duration of infections, and higher morbidity and mortality. So every 10 kilocalorie per kg decrease in calorie intake for first 5 days is associated with substantial increase in mortality rates. So what are the challenges in pediatric nutrition is early and adequate feeding. The guidelines talk of start early, feed adequately. What is the route administration, role of immunonutrients, gut-brain axis, glycemic control, and micronutrients in TBI. So I'm just dealing with early and adequate feeding, gut-brain axis, and micronutrients because I thought I won't be able to cover the whole aspect. So guidelines say that even the Brain Trauma Foundation guidelines, SPEN guidelines, or the American Enteral Parental Nutrition guidelines, they recommend that the feeding should be started early as maybe 24 to 48 hours, and the target should be reached within 7 days. And what is recommended is indirect calorimetry to measure the requirement of the calories. And in absence of calorimetry, prediction equations can be used. So apart from this, we have ADAPT trial, which had the third specific aim of talking about nutrition, the same, what is the calorie intake and the early institution and the glycemic controls. The data on this metabolic support is not yet out. So right now, for the estimation of energy requirements in TBI, we have indirect calorimetry or the prediction equations. So indirect calorimetry itself has its disadvantages and it requires an extra equipment. So generally we rely on prediction equations. So these prediction equations, they take in account the injury factor, which is around 100 to 250% following TBI. However, because of the recent neurocritical care practices like use of sedatives, barbiturates, analgesics, muscle relaxant, it is probably lower than expected REs are there. So predictive equations may overestimate the requirements. So most commonly used predictive equation is Harris-Benedict equation. And we use this equation to calculate the caloric requirements, and the generally resting energy equivalence is multiplied by 1.5 to find out the total caloric needs. So there is enough of evidence in pediatrics as well stating that early nutrition and achieving full calories is good. But overall, the days to achieve full calories and the deficits are generally not very well described. In this study, it is around 3.4 days to reach the full calorie targets. So we just for this talk, I try to compile a data of a previous 1 year for 100 pediatric TBI patients. So we saw that up to 48% we could start nutrition within 24 to 48 hours. So is just starting of nutrition is adequate? Probably not, because by day 3, only few percentage of patients could actually reach to the goal calories. And by day 7 also, we could feed adequately 25% patients only. So mean calorie deficits at the day 3 and as well as the day 7 were quite high. This is the cumulative over the first 3 days and over the first 7 days. And similarly, if we say that at day 3 and day 7, the planned and the delivered calorie, there was a significant difference between what we planned and what we actually could deliver to all the patients. Similarly was the findings of the cumulative protein deficit at day 3 and 7 and at particular day, that if we were able to achieve the targets at day 3 or at day 7. So what was the causes of delay in feeding? So generally the causes of delay in feeding was operating room procedure planned, some extubation or emergency procedure in ICU planned. So they became an important, so this is the thing which we can control probably. And even in the papers which have been quoted, this has been stated as in adult nutrition papers that this is a common cause of delayed feeding in ICUs. The other, like gastric residual volume or the feeding intolerance, which we say, that is also a significant cause. And among the pediatric patients, around 12% of them had vomiting issues and other GRV, gastric residual volumes. So the next is the gut-brain axis. So the gut microbiota, which is related in patients with traumatic brain injury. So after traumatic brain injury, the gut microbiota changes from the commensal to the pathological. So from our institute, we have a study on the adult TBI patients, not on pediatric. This is one from the pediatric TBI. So it states that children with severe injury are characterized by early depletion of commensal bacteria with loss of site specificity and enrichment of potential pathogens. So how this gut microbiome changes the impact, or giving a prebiotic or probiotic can help to reverse this gut microbia changes is important. Next is the micronutrients, which includes vitamins and minerals in various roles they have in recovery, like energy production, neurotransmitter synthesis, antioxidants. So there are studies which state that there is vitamin D deficiency, and it has a significant role to play in the prognosis after traumatic brain injury, not specifically pediatric TBI, this is TBI. So they say that vitamin D deficiency is associated with poor functional outcome at hospital discharge and mortality. Similarly, we have adult studies with vitamin E deficiency. So in our institute, we conducted this study, which is ongoing. So it's a preliminary data wherein 1 to 15 years of age children were enrolled, and we saw the levels of vitamins like vitamin A, B12, folate and D, amino acids carnitine, and minerals like iron, magnesium and zinc. So we could find that nearly 55% patients had vitamin D deficiency. The most commonest deficiency which we saw was the zinc deficiency. This was followed by iron deficiency. So at least 50% of the patients had 2 micronutrient deficiency at any point of time. So this whole thing states that the adequate nutrition, which should include macro elements like carbohydrate, proteins and fats, but also should consider the micronutrients. And the role of the gut microbiota should also be considered while treating these patients and specifically addressing the nutritional needs. So adequate nutrition is essential for pediatric TBI recovery, and nutritional deficits are common post-TBI due to metabolic changes and feeding difficulties. So nutritional interventions have potential to mitigate long-term consequences of pediatric TBI. Not inside the hospitals also, but at the time of discharge, these patients which are being discharged on tracheostomies and are going to families which are they are not able to take care of the children very well, the feeding instructions should be given to those patients so as to improve the long-term outcome. So we should not get emaciated children when they come at 6 months for a follow-up. So a better patient with a better nutrition score will surely have a better outcome. Thank you very much.
Thank you. Our next speaker is Dr. Deepak Gupta. Dr. Gupta is a professor of neurosurgery at AIIMS in Delhi.
Thank you so much. Thank you, Ikran, for this opportunity. Well, this we have seen already, that child is not a small adult, but the more important thing is that they have a longer life expectancy. So I think all the challenges which we deal in the management of these children, they live longer with the disability, and of course they are an economic burden to the nation also in case we don't address them well in time. Now there's some unique features about the pediatric age group which most of the people who are catering to the needs, they understand. They breathe more air. They are more anabolic, as Ashish just mentioned. They need more water, more calories, and they don't manifest with the shock so early. You know, the only manifestation in a child you may get is just some tachycardia, not the fall in the blood pressure. And many of these children actually, they deteriorate in the ED itself, because we all understand they have a very large head, almost 1:8 is the ratio of the fascia to the cranium. And those who are not dealing with the children, they won't be positioning the children very correctly, and so leading to the deficits. Other thing which we see very, very commonly in our ED, you know, like almost 3 to 4 cases happen in a year, wherein the endobronchial intubation goes to the right side. And this is mainly because of the inherent anatomical issues with the children. And we must understand it's just not the problem of the intubation in the right bronchi, but it is also the problem of, the cascade of so-called coagulopathy which happens subsequently, because when the tissue hypoxia, it leads to acidosis and it leads to coagulopathy. And then the neurosurgeon or the neurointensivists, they keep on correcting the coagulation factors, the PCC is not available, and then the children, they go to the point of no return. And this exactly happened just last month in our ICU when we had this child who came to us with polytrauma. And he had a left acute subdural hematoma with midline shift and mass effect. However, he could not be pushed into the theater because he had some amount of hypoxia, acidosis and coagulopathy. As you can see, the platelet count was quite low and his PT was also deranged. So we had to wait for almost 12 hours for this to be corrected. And by this time, the correction could take place. The child had already sustained hypoxic brain damage. Despite that, we went in and we did a decompression. Of course, the brain was quite tense and bulging. We did a kind of covered it with the Surgicel, took out the bone flap. The child did improve. The ICP did fall from preoperative 70 to 30. And then later on, because the ICP was refractorily raised, so we had to put this child on barbiturate coma. The child improved. The ICP dropped further. However, the child had a sudden cardiac arrest and we lost this child. In fact, this was the second child on the barbiturate coma in the last 3 years we lost. Otherwise, our experience has been fantastic with the barbiturate coma in most of the children. And this was the neurological response you can see on the third post-operative day when the child, just before the child was waken up during the barbiturate coma, he was improving, but he had a sudden death. So what are the challenges that we have in this age group? The foremost challenge I personally believe is about the guidelines. Most of the people, they talk about guidelines. Some people talk about local regional guidelines, or many of the hospitals, they in fact have got something called as SOPs in their setups. So, and nowadays we are talking about kind of consensual based or kind of comparative effectiveness research based guidelines, because now we have understood it's very, very difficult to do a large scale randomized controlled trial in any of the TBI subjects. So people are talking about CER based exploiting the heterogeneity of a disease or the heterogeneity of the data to get some parameters. And so there has been a lot of debate about whether to give mannitol or saline or to, ICP monitoring should be done or not to be done. It has been discussed previously about decompressive. Adelson just talked about prior to me, and barbiturate has also been discussed. I'll be just touching upon these parameters very briefly. So we do have some guideline available on 2019, and these are fairly decent guidelines, I would say. My personal take is that it's always better to follow some guideline. I mean, some guideline is better than no guideline. It improves your outcome in your setups. And as you can see out here, the hyperosmolar therapy does have a role. In fact, the bolus therapy does have level 2 recommendation in the latest guideline. The barbiturates have also been given level 3 recommendation in the pediatric age group as of today. To talk about the guideline adherence, the Pegasus guideline which came up with the Seattle group in the Harborview Medical Center, definitely there was, when there was an increase in the ICU adherence to these parameters, the outcomes did improve. And we noted the same with the Chirag and with the ADAPT guidelines. In fact, our mortality, if you see, had a significant drop from 40 to under 10% in the severe pediatric TBI. That was a marked leap, and we just least expected this would happen, but then it happened and the results are there. So I think the actionable interventions do improve outcomes in this age group. To talk about ICP monitoring, I think the only message I can give is that there is no controversy as of now in the severe pediatric TBI. If it is available, ICP monitoring is recommended and should be done, because it helps us in taking a decision whether to subject a person to a kind of a medical management or to a surgical management. Now, this was a child who came to us many years back, I think way back in 2008, a 7-year-old child. I mean, the CT looks, to somebody would say CT is normal, somebody would say it's a mildly edematous cerebral edema. The opening ICP was 15, and we inserted, and after 2 hours, the ICP rose to 40. And immediately the child was rushed to the theater, decompressive was done, and now 15 years later, he's a young engineering graduate. But then this calls for a very important point for discussion. Should decompressive connectomy, was it really needed in this child? Could we have given a trial of medical management? Because at times we just go for the ICP numbers, and we understand that ICPs, we have to see more of the trend, not just the number. The children, they have got a lot of vasogenic edema, which can be very well managed conservatively with the intensive medical management. So of late, in the last 15 years, we have actually significantly dropped down the incidence of decompresses at our center in the very young children, and we are managing them with the medical management. Whether we can hit the ventricles or not, I think the EVD is not so difficult in the pediatric age group, and in fact the contralateral ventricles does dilate, and in case it is indicated, you can very safely put the EVD. And in fact the ICP monitoring, the cost issues is the one which is being talked about. And we are using these intraparenchymal catheters at least 3 times in 3 different patients after ETO sterilization, and there has been no increased incidence of the infection either. So we have brought down the cost of ICP monitoring. And yes, nowadays this so-called ultrasound is available bedside. Most of our neurointensivists are very comfortable with doing optic nerve sheath diameters, and in fact the assessment for the ventricles to calculate. To talk about mannitol and the sugar and the salt, I think now the data is there from the ADAPT study, which shows very clearly that there's a lot of heterogeneity. Almost 27 different permutations and combinations of hypertonic saline was used in the series. But what we observed was that the bolus administration of 3% hypertonic saline was associated with the reduced ICP and the increased cerebral perfusion pressure. And the bolus administration of mannitol was the problem with the mannitol, and there is nothing against mannitol, I would say. We have been using mannitol for almost many years or decades, I would say. But it is just that the evidence is not there. Mannitol probably considered himself to be the undisputed champion, so naturally not much of RCTs are available. But now people are talking more and more about hypertonic saline, and it has more and more data is coming up wherein the reduced mortality is noticed with the hypertonic saline. Decompressive connectomy, again, I think in the resource-constrained environment wherein you do not have access to the multimodality monitoring, it's always safer to do it early and to do it big. However, as a matter of policy in our center, most of the children who are less than 2 years of age, even with the structural lesions, we try to manage them conservatively with the intensive medical management, which goes on to use the barbiturate coma also, and they do fairly well. This is the child who was admitted just last week with us with a bilateral blown up pupil, and he was M4, and he had a midline shift of almost 18 millimeter. We initially could not push the child to the theatre because he had a very low hemoglobin. We kind of resuscitated the child, and subsequently the opening ICP was 30, and this child was later on taken up for the surgery. And this is how the brain looked like. The brain was quite tense and swollen up. After the evacuation of hematoma, we did the duroplasty, and this is how the CT looks like 3 days later. The child has improved significantly. He is presently on midafenta sedation and is doing well and likely to be extubated in a couple of days. He has some infarcts which were there, in fact, pre-operatively, but the CT does not look so bad, and the ICP has dropped down to 4 to 5 now. So there are various pathways which we are practicing. Barbiturate coma is a very promising kind of a medical management in these children. In the interest of time, I will skip those. The abusive head trauma is something which is often ignored in our country, and we do see these patients time and on. Surprisingly, the ADAPT showed that the outcome in the abusive head trauma was not much different as compared to the normal patients. So we have the SOPs in our center, and the only take-home I would say is that you need to the adult physiology cannot be extrapolated to the pediatric age group. Bolus hypertonic saline therapy does have a role, though there is a lot of variability in the management of these patients. Lastly, I just want to close with 30 seconds that we see a lot of patients of fall from height. In fact, these are 9 children who were admitted in ICU on a single day, and all these children, they fell from height. And apart from the abusive head trauma and polytrauma patients, some of these children do survive and some do not survive. They actually end up becoming organ donors. And so what we do at our setup is we do send the social workers to the places where the children fell from, and we make some corrective measures, in fact, to the extent of building up the balconies if it was missing out there. The Neurological Society of India came up with this safe balcony, safe child, put in net to prevent a death. So at this platform, I will urge all the audience sitting out here to help us in promoting this initiative to the rest of the country, in fact, to the rest of the world, and make it a global campaign to save child, because we have, it's like a menace, I would say, fall from height. So I think we need to join hands and to save these children. Thank you so much.
Thanks, Dr. Deepak. Next speaker is Professor Moni Manitla. He will be speaking on decompressive craniotomy in children.
I will speak about post-traumatic epilepsy in children, if I may. Thank you again for giving me the opportunity to speak about this subject. We already heard about the epidemiology of head injury. I can tell you that when I'm hearing the lectures today, I'm happy to find out that there is consensus that for now there is no real consensus in treating children with head injury, but there are still a lot of work to do. And one of the biggest questions is what about the epilepsy following head injury? So this is a paper from 1998 by Anengers speaking about the epidemiology of epilepsy after head injury in adults. He described 15% of epilepsy in patients with moderate to severe injury. So before we reached our research, we looked for a real definition. What is the definition of mild to moderate severe TBI? And we found different definitions in different papers in the literature. Some of them spoke about GCS less than 12, less than 10 in 2 categories. The abbreviation in injury scale was also suggested. And Anger himself postulated that a mild head injury is a patient with no fracture, no loss of consciousness, and less than 30 minutes of amnesia. But actually, we use the regular term of mild, which is GCS 14 or 15, moderate 9 to 13, and severe less than 8, equal or less than 8. And I think that there, at least we'll reach this consensus that when we speak about the definitions of head injury, we'll use these categories. So the questions that we asked ourselves, what is the risk factors to develop post-traumatic epilepsy, and can post-traumatic be prevented? And actually, what is the incidence of post-traumatic epilepsy in children with TBI? So we performed a retrospective study along 4 years. In 4 years, we collected children with moderate to severe head injury, and children along of 2 years with mild head injury. We excluded all those that had previous epilepsy or previous chronic disease that associated with epilepsy. We excluded patients with other lesions in the brain, and we collected the data regarding these patients, including the demographic data, mechanism of injury, CT findings, and the hospitalization course. We used actually 2 phases. First was the retrospective phase when we collected data, and the second was a prospective phase when we conducted a phone survey for all these patients to ask if they are having seizures or epilepsy, if they are on medications. Those who had epilepsy, we invited for follow-up in our outpatient clinic, or those who are already being followed up in our outpatient clinic in order to refine their epilepsy, type of epilepsy and type of medications. Again, we used strict definitions. So immediate post-traumatic seizure is single seizure within 24 hours. Post-traumatic seizure is a single seizure more than 24 hours, but less than a week. And post-traumatic epilepsy is 2 unprovoked seizures more than 7 days from the injury. So we collected in our 2 categories. For mild TBI, we found 190 patients, but actually we could perform the study on 191 and on 95 children with moderate to severe. moderate to severe head injury. The average age for the multi-BI at the time of the injury was around 4, and then for the moderate to severe, around 5. Most of them were boys. We couldn't find any predictor with regards to the mechanism of injury to develop post-traumatic epilepsy. Well, we had only one patient with penetrating a head injury. With regards to the CT findings, we found out that in the moderate to severe group, only patients who had fracture and another feature in the CT, epidural hematoma, subdural hematoma, subarachnoid, brain edema, were in greater risk to develop epilepsy, but in my eyes, it's only a statistical thing and not a real thing, because there is no logic that patients with contusions or mass effect won't have more risk for epilepsy. And for the mild group, we couldn't find any CT characteristic, but we found out that the length of stay at the hospital was a risk factor to develop epilepsy. So this is the table of the patients with moderate to severe. 9 patients who developed epilepsy, 4 of them with intractable epilepsy, the rest of them with anti-epileptic drugs. The Glasgow outcome score was between 2 and 5. And for the mild patients, only 3 of them, well, 6 of the 191 developed epilepsy, 3 of them with intractable epilepsy. So this is an example of patients. These are 2 patients with moderate to severe injury. You can see that the brain is compressed. You see a minor bleed and fracture. And here you see the brain edema, some kind of pneumocephalus. This is a child with mild head injury that 3 of them developed epilepsy. This is a meta-analysis that was published a few years back, collected 19 papers on children that developed post-traumatic epilepsy. They looked for the quality of these papers, and as you can see, there are different qualities between the papers, and most of the papers you cannot really rely upon the results, but still they could gather it together, and they came into the exact conclusion that we achieved, that about 10% of children with moderate to severe injury will develop epilepsy, 20 times higher than the general population, and for children with mild head injury have risk of 8 times higher than the general population. Immediate post-traumatic seizure has no role in predicting post-traumatic epilepsy, but this is what we know. With regard to anti-epileptic drug, preventive anti-epileptic drug, I can tell you my rule: I don't give any anticonvulsant therapy for patients who are not having seizures. Although in the last protocol of penetrating head injury, the guidelines say that you should give antibiotics and anticonvulsant therapy to each patient immediately to each patient with penetrating head injury. So we don't really know what is the role of prophylactic anti-epileptic drug. We know that skull fracture with brain parenchymal feature abnormality in CT is a risk factor for epilepsy, and we know for sure that there is a need in solid clinical assessment at initial presentation and long-term follow-up. By the way, the paper that we published on mild traumatic brain injury was the first that followed the patient for the long term. And I cannot go down from the stage without mentioning Shira Bivas and their 2 kids that were kidnapped at October 7th. You can see the blood on one of the kidnappers and the horror on her face. It's now 5 months since she was kidnapped, and we have no knowledge about them. Thank you.
To Professor Moni. I think the question will be in the last after this session.
Okay.
So in continuation of the pediatric TBI in this session, the next speaker is Professor Hema Pendharkar from the NIMHANS Bangalore. I would invite her for her talk on abusive head trauma in children. Dr. Hema, please.
So, a very good afternoon to all of you. To begin with, we have these lines which are very meaningful, said by Professor John Caffey long ago. Guide well your baby's precious head. Shake, jerk and slap it never, lest you bruise his brain and twist his mind or whiplash him dead forever. These have been said almost more than a century and a half ago, which is the topic of my presentation today, abusive head trauma in children. And I must thank Professor Sinha for this invitation to include this topic in this conference today, and also my colleague Professor Dhaval Shukla, who encouraged me to present this and share it, our experience at NIMHANS with all of you. With your permission, I'll move ahead with the presentation, sir.
Yeah, please.
So it is defined as an injury to the skull or intracranial contents of a baby or child younger than 5 years due to intentional abrupt impact or violent shaking. It is also known in literature and over the years as battered baby syndrome, shaken baby syndrome, inflicted traumatic brain injury, non-accidental injury, whiplash shaken infant syndrome, and so many more names to it. But the American Academy of Pediatrics has now put it as abusive head trauma. Of course, this will change as our understanding of the disease process and the condition changes. The spectrum of understanding and imaging and looking into it from the perspective of child care has changed from 1860s till present, 2018 recently, and the guidelines have also been changing for all these children. Classically, it has been described as a clinical triad of subdural hematomas, retinal hemorrhages, and encephalopathy. The subdural hematomas, as we know in these children, would be something would be something as small as these subdural hematomas to these massive subdural hematomas in the anterior and posterior interhemispheric fissure, whereas we know that the SDH in the posterior interhemispheric fissure is considered to be very classical of abusive head trauma. Retinal hemorrhages, again, they are considered to be a hallmark for these conditions as such when looked at in the complete setup of these patients. They are characteristically bilateral in 85%, multiple, and extend to the periphery found in all retinal layers. Non-AHT RHs are unilateral, few in number, and located at the posterior pole. Coming to AHT proper, what we have considered so far in our setup in entire country is that it does not exist in India, and it is a problem which is restricted to the Western world. Very classically a problem of the Western world is our understanding of it. But the incidence of AHT, so as we have from the Western literature, is 14 to 40 per 1 lakh children, and we have which is similar to meningitis or lymphatic leukemia and other conditions which might be estimated in that age group of children. But what we know is that India houses the second largest child population of the world, with about 19% of total children in the world and 18% of them being below 18 years of age. Now, with that kind of a population, we have only anecdotal reports, only case reports from our country coming up about abusive head trauma, primarily because we have never suspected when the child comes that it could be abusive head trauma. Way back when Usain Bolt had visited India, he had said that in a population of 1 billion, it was 1 billion that time, it's 1.4 billion now, that he doesn't believe that in a population of 1 billion, there could not be a single athlete who could be his competitor or who could be at par to what he is as an athlete. The same holds true for abusive head trauma. With that kind of a child population, the second largest in the world, it is not possible that India does not have abusive head trauma. So how do we identify abusive head trauma? Fundamentally, we have to consider it in all children who present with neurotrauma younger than 2 years of age without any direct evidence of a car or a two-wheeler accident in our setups. In cases where there is a history imaging mismatch, this is absolutely fundamental to identify AHT in our setup because there's always a history imaging mismatch that we see in these pediatric patients. When the described trauma cannot explain the child's injury, and of course there's a past history of abuse which would more often go to a pediatrician and different physicians or surgeons in that sense. The clinical presentation of these patients will be very, very varied from irritability to coma. We do not know what the patient presents with. But unless and until we suspect that it is an abusive head trauma, we are going to definitely miss this possibility in these children. So it is in these scenarios that it is imaging which plays an important role. And that is our experience in NIMHANS as well. Because primarily, when we do not suspect it clinically, we send the child only for imaging. Imaging and finding of the classically described features of subdural hematomas, posterior interhemispheric fissure SDH, ischemia, hypoxia, all these would be pointers to the possibility of abusive head trauma. We can see the posterior interhemispheric fissure SDH here. There is also contusion, soft tissue injury, bony injuries, SDH on the contralateral side, in underlying hypoxic damage, and extensive supratentorial hypoxia. followed by, and this is in another pediatric patient, we can see there are large skull fractures in this child. So I'll give you some examples that we have come across in our setup. So this was a 2-month-old female brought to the casualty at 2 a.m. with a history of fall from bed. We are all aware that kids fall from bed, and we do respect to what we have seen in the previous lectures. These kind of subtle falls from the bed or slipping from the hand when we are sitting or we are sitting on the bed do not cause these kind of gross imaging findings what we are seeing in this child. So there is extensive hypoxia, complete supratentorial hypoxia with what we call the right cerebellum sign. A large parenchymal hematoma is also soft tissue injury that we are seeing in this child. It was not suspected to be abusive head trauma in this patient. The second child, an 18-month-old female, again fell from a center table, and what we can see is there is an SDH on the right side with midline shift and of course all other features that come with an SDH. It is also in this child again, was taken to an ophthalmology for evaluation, and the fundus showed that both eyes show multiple intraretinal and few subretinal hemorrhages, which were very much pointing with the history, with the imaging findings and the fundus finding that this could be abusive head trauma and has to be addressed to it from that perspective. There are a lot of investigations which are required to be done in patients or in children when they come with these kind of presentations, because we have to rule out other conditions that the child might have having at that point of time. The imaging workup of all these patients would include a plain CT at any point of time, CT of any area with a coexistent injury, skeletal survey, but absolutely essential is a fundus evaluation, followed by MRI brain or MRI spine, because there are a lot of findings in the spine also of these children when they come with abusive head trauma. Now, what we are saying is most of the time we will not have a history which is forthcoming in these patients that there was an abuse for the child, but we had this 3-year-old male who was brought to our hospital. The child himself gave us a history that his uncle used to bang his head against the wall and punish him with cigarette stubs. So these marks, what you are seeing on his abdomen, are because of that. It was over a prolonged period of time, and fundus showed optic atrophy with vascular attenuation. Only subtle subdural effusion on both sides. So there is a history of abuse in this child with recurrent head trauma that the child has sustained, but whoever had seen the patient had never considered it to be abusive head trauma in that context. The next case is a 3-month-old child, again history of fall from bed and loss of consciousness 1 day ago. The child had a fracture of C4, C5, also retinal hemorrhages and papilledema and Roth spots. So this is the CT of the child. In certain cases where we have a very subtle subdural hemorrhage or we are suspecting more injury, and again we don't find those findings in these children, we may go ahead with MRI in these cases. MR may not be feasible for every patient in our setup for so many reasons, but CT, yes, as the first imaging modality, followed by MR when it is required. This is a SWI image which shows extensive infratentorial hemorrhage, diffusion restriction supratentorially both sides. These are the corresponding ADC images which confirm that this child had sustained severe hypoxia. We have a team in NIMHANS. When we started looking at abusive head trauma cases that we had in our setup, we formed a group with all the people around, with my colleagues from neurosurgery, neurology, child and adolescent psychiatry, biostatics and epidemiology also, to look into this subgroup of patients. The problem or the scenario in our setup is that we are not looking at these cases longitudinally when they come to us. It is only a case report. Someone sees one case, and we say that I have seen only one case in my lifetime, which is not so. Probably our suspicion has to be very, very high. The workflow in our setup is, if a child comes to ER or OPD, he is evaluated obviously by the resident who's on call or the consultant who would be there. The team leader is informed. We ask for an imaging, fundus, skeletal survey, and the appropriate management is done, whichever is required depending on the conditions of the child. The child is then referred to, the family is referred for family counseling. And again, depending on the condition of the child, either the child can be observed, admitted, referred to the pediatric hospital, or most often, as in our scenario, the child goes home without our advice, like discharge against medical advice. It is not that we see abusive head trauma only in government hospitals where we have a very different socio-economic strata coming to us for evaluation, but also in corporate setups. This was a child who was 7-year-old when he came to us, but had a history of injury at 4 years of age. And then when he was evaluated, they did find fundus findings which were suggestive of abusive head trauma. So it is the suspicion in the given setup, wherever a person is, that you have to suspect it could be AHT and do a relevant workup for the child which is required. There are 4 hemorrhages on the right and 2 in the left in this child. There is a large list, a long list of mimics of abusive head trauma because it has a lot of implications when you say that it is abusive head trauma. These all have to be ruled out before we put it. A certain injury has to be abusive head trauma. The list primarily includes birth-associated SD depending on the age of the child, infection, vitamin D deficiency, osteogenesis imperfecta because the child can have several long bone fractures associated, hemorrhagic disease of newborn, benign enlargement of the subarachnoid spaces, glutaric aciduria which is again associated with SDH, minky kinky hair associated with SDH, CVT also associated with SDH sometimes, and things like that. That's an example to show you that this was a 3-month-old male who was brought to the hospital with a history of, irritability. And then the child had an extensive subdural hematoma, as you can see here, with underlying hypoxia. This is an old case. We had no details in the file, but the child was considered, the diagnosis written in the file is whether the child harbors clotting factor deficiency, as we saw in the previous lectures. But the child was never investigated for anything else that the child might have had. I'll require a few more minutes, sir. I'll just complete the slides, 2 more minutes maybe. So the child was discharged against medical advice against any kind of a workup at that point of time. As for SDH, there are several mimics of retinal hemorrhage also which have to be ruled out in the given setup. How do we deal with the management of these children? Of course, medical, surgical, family counseling, social and legal, which is a very important part of how do we deal with these children. But there are several practical problems that all of us face in our setups. First and foremost being an incomplete history when the child comes to the ER, or even if transmitted, incomplete clinical examination, regrettably so. Incomplete clinical workup, again, there are several explanations to why the workup is incomplete. Incomplete data entry. Discharge or referral is again incomplete and the child may be lost to follow-up. For follow-ups, we have incorrect phone numbers, change in addresses. We have tried tracing the patients back and calling them back, but sometimes it doesn't work. But what is important, why do we need to follow these children up, is that the outcome of these injuries is very grave. Mortality is very high. Morbidity, of course, if the child survives in the long term, is a socio-economic burden on the country as it goes ahead. And of course, we know the long-term outcomes can be very devastating for the family. That's an example of that. 5-week-old child, no details available, SDH on the right side. We had no clinical details, but the child came for a follow-up. Follow-up imaging is there. So imaging shows that there is a significant atrophy of the parenchyma after 2 weeks. And this is the kind of imaging follow-up that we have. We know what the clinical outcomes in these children might be, and it's very important that we work up on these cases subsequently. Coming to the legal aspect of it, we have no laws in India specific to abusive head trauma as in the Western world, because they are very stringent about how to deal with a child with abusive head trauma. So we have still to identify the cases, we have to work on them, and then only we will be in the process where we can formulate law for abusive head trauma. We must know that it does exist in India, AHT does exist in India. Awareness has to be increased many fold. Absolutely every time that you have a child with an SDH, the first thing that should come to our mind, is it abusive head trauma? Overread it and overwork it and then come to another conclusions by ruling out abusive head trauma. Extensive workup is required, yes, we know that. Multidisciplinary teams are required to handle these things, and the teams should look at it longitudinally, not saying that I have seen only one case in my career and that AHT does not exist. Be more diligent on working on these cases. We have to take personal interest to work on these cases so that we identify them more and more. So when we reviewed our cases at NIMHANS, we came across 48 cases over 8 years that we had. Only 7 of them had a complete workup with fundus evaluation and things like that done, but we also did not have, as I said, a complete history and a complete workup to 100% call it this was AHT. But the thing was, in these patients, we had the imaging which was suspicious of AHT, and then we looked up the cases, the idea being to put it across that we do have AHT in our country and we need to look it up. We have to identify these images which are pointers to AHT, and of course we have to suspect. We have to train our people, anybody who is working with us. We have to be persistent about looking at AHT. We have to have a good follow-up of these cases and review the cases from time to time. We cannot forget that these cases are pointers to abusive head trauma. There's a huge literature which we must review before we come to our own formulating our own guidelines and concluding it to be AHT. And of course, to conclude the presentation today, what I would say is that we have all looked at the stars. We have all gazed at the stars at some point of time or other. Some of them are small, some of them are bright. But then it is only when we join the dots together that we know that it is a constellation Saptarishi in this case, and it is only then that we will identify what we are looking for. So we need to identify abusive head trauma with a very high index of suspicion so that we don't miss out on it. Thank you so much. Thank you.
We're over time. Yeah. So the next speaker is Professor Ashish Pathak from Chandigarh. He's speaking, and now the Director of Neurosurgery at Fortis Hospital in Mohali. He's going to be speaking on minor head injury. How minor is it?
Thank you, Chairpersons. At the onset, I must thank Dr. V.D. Sinha to accommodate me in this meeting, actually. This is not confined to the children, but it's in general. And let me tell you, the first statement I want to make is that I'm always scared when there's a mild head injury, actually. They're difficult ones to manage. We have definition for mild head injury where we know there's loss of consciousness for approximately less than 30 minutes. After 30 minutes, the GCS should be 13 to 15. The post-traumatic amnesia should be less than 24. And the other alterations and changes which we see. And of them, the post-concussion syndrome, as was already pointed out by Professor Vaughan, that it is a problem. And you have a dizziness. It's a galaxy of symptoms, not single one. They can present in various ways. They can come in combinations. There can be headache, irritability, depression, anxiety, insomnia, alcohol intolerance. There are other personality changes, sexual abuse, inappropriateness, apathy, so a host of them. So they conglomerate and create a lot of problems. I would concentrate on post-traumatic syndrome. And before I go into that, let me give you some statistics. 10 to 15% of the patients of mild traumatic head injury would go into some sort of prolonged symptomatology which will last for more than 3 months. And just imagine the statistics in India, 1.5 to 2 million head injuries a year. So that means you're having 1.2 to 1.6 million mild head injuries a year. And then you're having 120,000, 160,000 patients of those who would persist with this mild symptomatology and will bother you again and again and come to your OPD and clinic. So what's the pathogenesis? You have got anatomic, you've got neurometabolic, and your physiological changes, which initially we used to just see a CT scan and say, oh, that lacks of normal, nothing to worry, everything is fine, go home, he's malingering, something like that. And generally in the lower socioeconomic group, they will say, oh, he's just fine, he's malingering, so don't bother about it. But now, we know that they can persist for various reasons. There's a neuropathological basis, there's a neuropsychological factor which add to it, but there are some controversies also. There can be a diagnostic problem if a patient is having underlying issues. And another thing, of course, sometimes you see, now it's coming up in India, but it's common in the West, is there's potential litigation issues. There may consist evidence that somebody was seeking to get some financial compensation, and it must be assumed that the symptoms arise solely from the pursuit of secondary gains. And there are people in India also will come and say, can I stay in the hospital for a few more days to show my insurance that, it was severe and things like that. So if you're cautious about that, they would try to play their symptoms very well. Now coming to the issues, there are long-term disability deficits, working memory, which can resolve quickly or last indefinitely. There are risks of health issues like binge drinking, depression, neurodegenerative disease, post-traumatic epilepsy, and things like that. And of course, they contribute to the factors in the long-term dysfunction and diminish the quality of life. So you must remember that. So they're not simple things. Do we have any evidence to show what is happening in the brain? Now that we are in the era of the MRI and the DTI, there are a lot of things which have been picked up. And they show the axonal tracts being changed, the retraction bulbs, the edema, the disruption integrate the myelin surrounding the axons, and thereby the reduced anisotrophy. And these anisotropic changes are picked up very well at DTI. So DTI, if you want to objectively sort of show, DTI is a good tool. And this is how we're now understanding the so-called changes in the mild head injury, which initially is to pass off as normal in other modalities of investigations. So this is, you go to the finer details. As you can see, there is a change in the myelin also, which can be now picked up. So we can objectively prove. And if somebody is in a habit of having repeated trauma, you can see that the initial trauma had this sort of injury and the subsequent trauma added to that injury. So you can even follow these patients up. So we have got objective evidence to prove that there is something going on in the brain. At the same time, we have to be also very careful about various differential diagnoses, and these might already be there pre-existing in that patient, and that can be just exaggerated. So just don't sort of add the very first blunt effect that it is the trauma only. You have to also know the background history of this patient, which will definitely make you clear whether this is some add-on effect or it is actually something new which has come. Sports injury is a major issue, and just the statistics of United States as they collect it shows that there are 100,000 mild traumatic brain injury from sports. And they present with something slightly different. Their days, they see stars, flashing lights, ringing in their ears, slurred speech, double vision. They run in wrong direction. They sometimes behave abnormally in the field. So that should be taken seriously. I would now emphasize on what I face as a very daunting task in managing mild head injury patients. Let's start with the sports again. So these players should not be allowed to return to play immediately. They should be looked and observed for physical and cognitive changes. They should not be left alone. They should be graded to return to play. And then they should come to play when they're actually asymptomatic and rest and exertion. So there are stages in which they are rehabilitated to. So initially they are into no activity, then they're going to light aerobic exercise, then they're going to sports-specific training, then they come into non-contract drills, and then followed by contract drills, and then get the clearance to go back to the normal play. Anything in the body goes physiologically wrong, rest is the best treatment. You have got a diarrhea, you give rest to your guts. So same is for the brain, and the brain needs more rest. So that is to be understood. So there should be off work or off activities. Now, there are certain things you must educate the patient. The patient is anxious, the family is more anxious. In Indian setup, the family is terribly anxious, let me tell you. So they must be informed that this is a symptom. They should be assured that it will improve, it will recover. Give some time and advise how to cope with it. And then you have to show how to gradually reintegrate them into normal life. And sort of that needs a time to discuss in the OPD. Just don't leave it alone. There might be several sittings. And gradually as the patient changes, you keep on educating them. There are certain things which have to decide in the hierarchy, the priority of your treatment in these cases. So few things which are very much important to the patient, looking depressed, irritable, behavioral problems, sleep disorder, headaches. So these might get a priority, because once you take care of these, probably the other symptoms seem to be less important to the family or the patient. And then secondary symptoms like balance, dizziness, cognitive impairment, fatigue, tinnitus, noise. So you have to understand memory is a very important thing. The episode of memory impairment is 13%, and specifically executive dysfunction becomes 9.4%. So in these patients, if you have to approach, you have to find all these issues. So the evaluation of the patient even by neuropsychologist is extremely important, and you should have one nearby, if not in your own hospital, which would dig up all these issues, because the patient apparently looks fine, talking, smiling, but there can be problems within. Post-traumatic headache, very important. 47 to 95% of the mild head injury patient will have some sort of post-traumatic headache. So this is very important. So they can manifest in the form of chronic migraine, chronic tension types, primary stabbing headaches, occipital neuralgia. Some headaches are unclassified. So you have to treat them in accordance to their presentation and the symptomatology. So establish the headache-related disability. So you have to find out, are they going to school, not going to the work, how much they're missing out, are they not going to recreational activity, they're not going to bed. Establish the average, minimum, and maximum daily activities which they are missing out, and whether they're taking over-the-counter medications, and what are they doing. So all these things would give you an actual idea, a scale of what sort of disability they're having due to headaches and how to counter them. And then treating the headaches need also a little bit of guidance about the lifestyle changes. So consistent bedtime, waking time, avoid sleep deprivation, avoid delay in your food, adequate hydration, minimizing the stress, avoid mobile phones nowadays, I would say. This is one of the things, very common things, and go into some outdoor activities, walking, exercise, and things like that. And if needed, a short-term support by the pharmacotherapy. Pharmacotherapy is very important. So NSAIDs, aspirin, paracetamol, these are helpful. Sometimes you need the migraine medications also. And the narcotics can be used in small period time just to sort of take over the acute phase of these headaches. And of course, to top it up, you need to have some sort of prophylactic therapy, which might be in the form of medications. And then gradually you have to see that you gradually taper them up. They don't become hooked to it. They don't become dependent upon it. And should be within 12 weeks, everything should be sort of weaned off ideally. And if it's necessary only, then you continue for a longer period of time.
Also, you have to characterize the headache. Sometimes it might be tension-type headaches. In that case, an amitriptyline might be a good proposition. And of course, if there's sleep disturbance, that will also help. And then you can supplement with gabapentin. If there's migrainous headache, you typically go into the way that you treat the migraine patients with a tricyclic antidepressant and the topiramids and the gabapentin. So there are first line, second line, third line. If somebody is having hypertension, a beta blocker would also help at the simultaneous addition to the group of drugs. If the patient has obesity, topiramide may be helpful. So all these things have to be judged. So you need to really go through the whole profile of the patient rather than deciding. And in extreme cases, people have tried botulinum toxin and occipital nerve root blood. Occipital nerve root blood, let me tell you, I've tried in 2 patients, works extremely well. And they feel so, once you break that cycle of headache and spasm and pain and all those things, it just breaks the cycle and it makes the patient feel better. It's a very simple procedure to do. Another important thing, very common in the Indian scenario, is sleep disturbance. And the literature says that 30% will have this in the first 10 days and up to 50% up to 6 weeks. So goal is to improve the continuity and restore the normal sleep. So relaxation is one way. Pharmacotherapy should be short term. The patient should not get hooked to it. And then, of course, you have to see that the long-term hypnotics are avoided but may be needed. The other aspect which you miss out and the family tends to overlook in the Indian scenario is that they have symptoms which suggest mental health disorders. So they have to be screened for depressive disorders, anxiety disorders, irritability, substance abuse disorders, and of course somatoform disorders. So you have to go into the background history properly, and here a neuropsychologist can really help you actually to pick up all those things. And then, of course, if they're really complex and you're seeing that things are getting out of hand, a psychiatric consultation might be very helpful, and they can help to take care of the complex and severe presentations. There's suspicion of psychosis, a bipolar disorder, or risk of suicide, ineffective initial treatment, and failure of family medication strategies. All these things are important where the psychiatrist can chip in and help you out. So, if you see, the mental disorder itself is a big aspect. General measures, medication trials, selective use of certain drugs like serotonin, combination of various sedatives, analgesics, anti-migraine drugs, and the follow-up 1 to 2 weeks, then every 2 to 4 weeks. And then last, not the least and very important thing I would say, this is the cognitive behavior therapy, which is very much important in these cases. Coming to the lesser things which trouble the patient, but they do trouble them, is the balance impairment. 30 to 65% patients of mild traumatic brain injury will suffer from dizziness and disequilibrium. This might be short-lasting, long-lasting. And these are usually the maneuvers for the benign vertigo, which will help, vestibular rehabilitation exercises, therapy, and some drugs to add on, like sinerizine and things like that, might be helpful in these patients. Fatigue. Very important and very common, and it varies from 21 to 73% depending on the severity of the head injury. So you have to see, gradually you must induce the patient to increase in the activity, slowly pace them into improving, they're getting better. And if the fatigue persists with the low mood, then you have to add some medication. Coming to the last bit of it, the brain injury rehabilitation. It needs a comprehensive neuropsychological analysis. There is a special battery of tests designed. Somehow the Western batteries don't fit well, but I have to say different institutes have their own, and NIMHANS have got a good battery of tests, which I find very useful. The functional strength and weakness is to be decided first before you embark on any sort of rehabilitation programs. Somehow, the cognitive rehabilitation problems are more found in the lower educated level group. Probably the brain is tuned to some different kind of sort of circuit system. And they have got 2 aspects. One is restorative function, and one is the learning, restoration through learning process. If you have got a status where the brain can re-network itself, you help in the restorative function. You get back to what you were. Otherwise, you have to go through a learning process where you re-educate your brain to go into that. So, these persistent cognitive difficulties like attention, concentration, ability to focus, all those things create a lot of problems, and does prevent them from going back to normal work. They cannot persist for a long time on the screens, or if it is an IT person, he finds it very difficult to engage himself in his work. So these are the things which are to be looked into. And so persistent cognitive impairment, learning of the compensatory strategies. So you are taught about this strategy. Just a couple of slides, please. So these strategies can be helped again now by various electronic gadgets or other methods where you can organize the patient to gradually come back to his normal activity depending on the particular activity, specifically those in the mental activity. The IT sector, young guys, I find they find it a lot of difficulty to go back to IT work. Working in the computer for 8 to 10 hours is real stress for them, and this really goes haywire. So if I have to conclude in this short span of time on this vast subject, which I think is and a difficult subject for me always, is treating symptomatic mild head injury is a team effort. So don't think that neurosurgeon can do it alone. Just forget about it. Each patient of symptomatic mild head injury is different and complex. You have to really understand them. Each patient is individual. There are no identical patients. Clinician must devote time to evaluate the outstanding issues which they confront. Best strategy is have a good team effort. However, the neurosurgeon should be able to initiate the basic management, and then the individual specific treatment strategies are very helpful, and it goes to various persons to retrain himself. Thank you very much.
Thank you, Professor Patel. Now I invite Professor David Edelson from the United States. He will be speaking on neurocritical care with children after brain injury.
Thank you again, Mr. Chairman, and again, thank you for all of your patience. I'm going to hopefully tie some of the acute management together. Should work. Just tie some of the management together that's been discussed by the other speakers. So I'm going to talk a little bit on neurocritical care. I've already provided my disclosures. And again, this is also one of my important points, again, for us talking today about pediatric TBI. It still remains the leading cause of death and disability. But we believe that that death and disability is really accentuated because of the extension of the secondary injury. So unless we can prevent the injury, or apropos to our last speaker, start to look at rehabilitation strategies, we need to really focus on these secondary injury mechanisms. The reality is that we have really simplified brain injury in such a way that it is not realistic to think that we can look at a single brain injury and be able to define a single protocol. The reality is that the phenotype is different from patient to patient. The diagnosis is different from patient to patient, their optimal recovery. And so because we don't have a lot of the trials and studies that help us to define the optimal approach, we have to take into consideration that individual variation. And when it comes to something like traumatic brain injury, it makes it much easier for us to look at things much more directed if we understand what's going on in each patient and take a more precision medicine approach. Again, to highlight, we know that aggressive early evidence-based protocols lower morbidity and mortality, and our present-day therapy is really the avoidance of second insults and lessening the second injury. So the only way for us to do that is to monitor the patient in real time, and so our therapies will be directed at what we find in that ongoing secondary brain injury. I showed this slide the other day, but suffice it to say that unless we can prevent the primary mechanism, and unless when we start to look at the tertiary aspects of care, which is rehabilitation, it's this interplay of insults and injury that end up leading to the final outcome. And so suffice it to say that when we talk about traumatic brain injury care today, we either prevent or mitigate it. We either are able to now take the brain injury and improve its outcomes, or in this particular talk is focus on the delivery of evidence-based care. I referred to the guidelines earlier, and I won't belabor them, but unfortunately, the guidelines right now, present-day therapy is ICP directed. And so when I get asked, should I place an ICP monitor or not, the real concept that I want you to take away from this is, do I think that ICP monitoring is an end-all? Of course not. But I would say that at least relative to our technology, treating TBI without knowing the ICP would be like treating diabetes without knowing the serum glucose. And remember, we used to do spot checks of glucose. Then we started to do them more frequent, especially when we were delivering insulin. And then we started to get into continuous glucose monitoring with then treatment with insulin. And then now we're at a point where we have a closed loop system where we monitor glucose and we can deliver insulin with an insulin pump, which changes based on the patient's needs. And I think that's really where we need to go in brain-directed therapy. Well, we also have CPP, and again, this is just a derived definition. And apropos to previous speakers, we have some what we believe to be acceptable parameters for ICP and CPP, but none of these numbers are defined, but one should consider scaling your treatment based on the age of the child. So treating an infant and going for an ICP of 22 may not be really the optimal approach. Well, the guidelines do provide opportunities for an algorithm and clinical pathway, and we know that those will improve outcome. These are just the pathways that are delineated in the third edition of the guidelines. This is just the first tier therapy, and I showed this clinical algorithm that is in the third edition and provides these different pathways. So we have the linear pathway for ICP, we have a surgical pathway for herniation, we also have a cerebral perfusion pathway if you are going to go along that direction, and there's also if you have brain oxygen therapy, you would be able to deliver another pathway that works in correlation with these different opportunities. Now, you can see that they don't really interact. They're very linear, and that's what I'll highlight a little bit later. With regards to second-tier therapy, no real surprises here, all standard treatments that have been around for a while. There really isn't any difference in this sort of second-tier approach than what was seen in the previous guidelines. And again, here's the algorithm that one can find in the third edition with regards to this care. But as I alluded to the other day, I think our approach toward neurocritical care is becoming more of an individualistic one, a precision one, and this is going to depend on data. That data is going to come from multiple technologies. Our modern day neurocritical care unit is not just an ICP monitor, it's a series of monitoring in order for us to measure the pathophysiology and the physiology in real time. So in this instance, you can see the patient with a monitor in. This child has not just ICP, but brain oxygen. There's also obviously the med tree, transcranial Doppler, temperature regulation, EEG, and then a system in which to consolidate all that data and be able to read it out to provide you an ongoing moment-by-moment basis for treatment. We have very standard ICU monitoring that is available, and there's a lot of information that you can derive from that, as well as other neuromonitors that are available. We know that there are there's low utilization of those, but as you incorporate each of these parameters into your thinking on these patients, it will obviously lead to an improvement in our understanding of what's going on pathophysiologically. And as I've mentioned before, is the data just the data? And really, how do we integrate all that data is really where I think the technology is going, and as I alluded to, in the future. Present-day therapy, unfortunately, right now is oftentimes just ICP, and it's high versus low, and we have a decision tree of treat or don't treat. But as I mentioned, I think there's more to it than that. We do have the thresholds, which I mentioned a bit earlier, but we also now have waveform analysis, which really does enrich our view of which way the patient is going and how much compliance or lack thereof that there is. We can see normal ICP waveforms as well as abnormal ICP waveforms, even despite the fact that ICP may be normal. And so, again, when one looks at more to ICP monitoring, we can look at CPP, as has already been mentioned, but we can also start to understand cerebral autoregulation. And as it was beaten into our heads during our residency, you know, the physiology changes, and the traumatic brain injury also changes that physiology. And we need to start to look at these things in a much different way. It's not just a simple curve of, you know, passive collapse or passive vasodilation with elevations in the ICP. We can now see that cerebral vascular reactivity is much more common with abnormalities in patients that go on to die. And with that, we now can start to look at perfusion optimization. So in this case, using PRX, we can start to define what would be the optimal cerebral perfusion pressure. And there's now even an algorithm for us to make that decision for what would be the optimal CPP for those patients. With ICP and CPP, we can see a lot of different derived measures, and with those increased derived measures, unfortunately, we still need to learn what is and what needs to be treated, but I think that's really what makes this exciting. Just with ICP and CPP, we can derive a lot of knowledge of what's going on with these patients and be able to move forward the field. So it's not just simple high and low. You can add other parameters such as brain oxygen or TCD or other types of parameters, and these will give you a lot more decision-making capability for treat or not treat. This is a great example. Here was a patient who's, you can see, very high ICP, was holding on with regards to brain oxygen the first couple of days. They went in contradistinction to one another. Here, ICP was brought down, brain oxygen seemed to go up, but then you can start to see them move in tandem. Here was an instance of brain ischemia. In this instance, now we're starting to deal with hyperemia. So in essence, we need to really take these areas of chaos and confusion and create an integrated system which is now available out there. And I think that once we now take this conglomeration of data, we can, in present day, not in the future, but present day, start to create red, yellow, green signals for when patients are doing well or not doing well. So with that, in summary, again, I would say that these evidence-based guidelines and protocols can lower morbidity and mortality, and when I would encourage their incorporation into your everyday use. It's about avoiding second insults and lessening that secondary injury, but we cannot do this sort of precision care without real-time integrated information. This means that we need to measure more, monitor more, and that will help us understand these things in real time. I think that the future is data analytics, as I mentioned previously. Once we have an understanding of what's impactful or not, we'll have a better understanding of what we can do to treat this. And so with that, I thank you, and again, much appreciate your time.
Thank you, Professor Edelson. I like the tagline, what you said is that without monitoring the ICP, how to treat TBI is like without monitoring the sugar, treating the diabetes. Thank you, Professor Edelson. Our next speaker is Hiroshi Sensei Karibe. He is the professor of neurosurgery Department of Neurosurgery, Tohoku University School of Medicine in Sendai. I know many of the people have heard about the Sendai cocktail in aneurysm surgery used in the past. Professor Hiroshi will speak on usefulness and limitations of TBI in guidelines.
Thank you for Chairman. Today, I present usefulness and limitations of the Japan TBI guideline. No COI. In 1990s, TBI due to traffic injury in younger generation is a big social problem in Japan. This polygonal line graph shows the annual number of patients with traffic injury who were transported by ambulance in Sendai, Japan. The x-axis is the year, and the y-axis is the number of patients. The colored line is the number of dead, severe, moderate, and mild patients, and the white line is the total number of transported patients. As this graph shows, the incidence of traffic injury reaches to the peak in 1990s. Actually, traffic injury in younger generation occupied the largest part of severe TBI. This bar graph shows the distribution of severe TBI by age in 1990s. The x-axis is the age of patient, and the y-axis is the incidence of severe TBI. The traffic injury in younger generation occupied the largest part of severe TBI in 1990s Japan. Therefore, the severe TBI, especially due to traffic accident in younger generation, seemed to be targeted for Japan TBI guideline. Japan TBI guideline has been proceeded since late 1990s. The latest version is the fourth edition, consists of A5 format 240 pages. It is customized to adapt Japanese medical and insurance system, social consensus, medical resources, and so on. As references, approximately 700 references are cited, including latest 243 out of 13,000 English and Japanese searched references. In addition to the revision and improvement of TBI guideline, pre-hospital, primary and advanced care, and expert guidelines have established concurrently. As background, it has been reported that the adherence to the guidelines are related to reduced mortality. The purpose of this study is to investigate the usefulness and limitation of Japan TBI guideline by analyzing the data from Japan Neurotrauma Data Bank before and after guideline publication. Using JNTDB, patients with severe TBI suffered from traffic accident were selected for analysis. Age, gender, patient situation in traffic accident, GCS score on admission, and Glasgow Outcome Scale score at the time of discharge were compared between before and after Japan TBI guideline establishment. As a statistical analysis, chi-square or Mann-Whitney U-test was utilized, and statistical differences were considered significant at p less than 0.05. JNTDB is 2 years of TBI patient registration project with the participation of 32 facilities being conducted intermittently. As project 1998, 2004, 2009, and 2015. Inclusion criteria of this database is as follows. Results. This is a summary table of the background of patients with traffic injury. As this table shows, age, gender, patient situation in traffic accident are not statistically different between groups. The severity expressed by GCS score on admission is not statistically different between groups either. This component bar chart shows GOS in all cases suffered from traffic accident. The bar on top is the project 1998, and the bar bottom is project 2015. As this bar chart shows, the mortality was significantly lower in project 2015 than project 1998. But favorable outcome shown as GR plus MD, was not significantly different between them. Focusing on patients with traffic injury in younger generation, which seemed to be a main target for initial guideline. As this table shows, age, gender, patient's situation in traffic accident are not statistically different between groups. This component bar chart shows GOS in younger generation suffered from traffic accident. Regarding the outcome in cases with traffic injury in younger generation, not only mortality, but also favorable outcome significantly improved. Discussion. In general, it has been reported that the adherence to guidelines may reduce mortality. Regarding TBI, it has been reported that the adherence to Brain Trauma Foundation guidelines seems to be associated with lower mortality. In Japan, it has been reported that the adherence to Japan TBI guideline is significantly associated with lower mortality. It has been also reported that the preventable trauma death seems to be decreased. The present results suggest that Japan TBI guideline is useful to reduce mortality in patients with severe TBI, especially in younger patients with TBI suffered from traffic accident. It is suggested that the Japan TBI guideline is quite useful to improve not only mortality but also functional outcome. Actually, the compliance to the Japan TBI guideline has been increasing from 18 to 72% in major facilities, which has a neurosurgery department, parallel to the improvement of the outcome. In addition to the usefulness of the guideline, limitation has been also suggested. For example, approximately 30% of facilities are still uncompliant to the guideline. In these facilities, lack of neurosurgeons and/or equipment shortages seems to be a major reason for failure to conform to the guideline. Changes of TBI patients with the times may be another limitation of guideline. For example, this graph is the number of patients by age in JNTDB. The x-axis is age, and the y-axis is the number of patients, and the color bar shows each JNTDB project. This graph shows that the number of severe TBI in younger generation is decreasing year by year, and the number of severe TBI in the elderly generation is increasing year by year in contrast. Limitations has been also suggested in the elderly. This component bar chart shows GOS in older generation suffered from traffic accident. The mortality was significantly lower in Project 2015 than Project 1998, but different from younger generation, favorable outcomes was not significantly different between them. In conclusion, the present result suggests that guideline is useful for clinical practice to improve outcome, especially in traffic injury in younger generation, the main target for the guideline to be solved. A limitation of current guideline is also suggested, as only mortality but not functional outcome was improved in elderly patients, which should be solved in future. Thank you for your attention.
Good afternoon, hello. Good afternoon, everyone. First of all, I would like to thank Professor Sinha for including my talk in the last session as a concluding talk. So now I would like to speak a little bit different topic rather than TBI in pediatric population. So my topic is related with some technology, the 3D printing and its use in craniovertebral junction trauma. So the topic is 3D printed models as an assisting tool for management of CVJ trauma. We all know CBJ is the region of transition zone between mobile cranium and vertebral column, which collectively constituted by occiput, the posterior skull base, atlas axis, and all other supportive ligaments. Injury to this region mainly manifests as atlanto-occipital dislocation, atlanto-axial dislocation, hangman fracture, Jefferson fracture, etc. And the typical incidence of this injury is 5% of all cervical spine injury. If we talk about the age distribution, it's around the most common is the 4th, 5th decade in the adult population. However, it's in pediatric subgroup, it is usually present in less than 5 years. Male-female ratio is 2:1. Historically, this trauma is considered one of the fatal trauma. But with the improvement in the pre-hospital care, now we are getting more and more survivors who encounter for the proper management. And the management of the CBJ trauma is maybe the conservative or surgical. Conservative is required nowadays less often. However, the surgical management of the CBJ trauma require having some inherent challenges, like the CBJ region is having complex anatomy. However, many times we encounter that we found even in trauma the abnormal anatomy, and it is even more complex. It also harboring the multi-direction movement in this region because of flexion, extension, lateral bending, rotation, and all those. So because of the high range of motion in this area, there is a chance of dislocation during the surgery. Other challenges during the surgery of this region is anomalous course of the vertebral artery and use of the sharp instrument like drill in vicinity of the important structures like neuraxis, spinal cord, and the vertebral artery. And many times we have to perform these procedures under some blind manner, like under C-arm control rather than direct visualization. So we often have, many times we have not full control on the surgery. So all these facts says that the CBJ surgery, CBJ trauma surgery requires high skill and expertise more than any other surgery. And the margin of error is very low in this surgery because any single error or a single injury to vertebral artery or the neuraxis may be the fatal to the patients. Because of the high range of motion, it's difficult to give favorable result every times. And because of all these facts, this is having the long learning curve and resulting into the restricted surgery to some senior surgeons only. So we have some measures to overcome these situations, like better understanding of the anatomy of that particular region. It helps to perform the surgery. And with, apart from that, we have to well aware about the vertebral artery course with the depth perception. And we have to have the well understanding of the direction and trajectory of the screws. And if we have the opportunity, then we have to rehearse before the actual surgery in skill lab and other settings. So how we can make this CBJ surgery safer with better result and with short learning curve. Before I move the fact, I would like to emphasize our learning cycle, how we learn the procedures. It involves basically the 4 stages. First stage one is the unaware incompetence. When we impart the knowledge, means awareness, it becomes the aware with incompetence. When we impart training over this, it becomes the conscious with competence. And when we practice more and more, it becomes the unconscious incompetence, means the surgery on your reflex. So if we are able to get the patient's customized anatomy outside the body, so it will offer us to study the CBJ anatomy 360 degree in all manner. And we can practice also in the real, kind of the real manner over that particular models. So the answer is for this is if we can make the customized 3D model of that particular region. Here is we are demonstrating a model having malaligned craniospinal axis. It's very well showing the spinal axis is cranial axis going here, spinal axis going here, with rotational abnormality with dominant left side vertebral artery, and the right one is passing over the joint. We can study in anterior, posterior, lateral, and all manner. Here is one more model showing vertebral artery. And here is one more model with rehearsal and practice. So what extras we get by doing, by printing this 3D printed model? The first is we find the exact anatomy of that particular patient outside their body. And it helps us to understand and get 3D orient about the complex anatomy of that particular region, because we have to memorize that particular anatomy in our mind before going into the surgery. It may also offer us the vertebral artery course with depth perception, orientation of C1, C2 joint, and thickness of the C2 pedicle, pars, lamina, and all those things. It also offers to identify the insertion point, it also acts as a template for practice and results and make familiar for important surgical landmark. It also aware us before and planning for the whether we reach to C1 or not. So plan B occipito-cervical fusion should be able to make preoperatively. It also offers us to contour and make and measure the size of the screws. So ultimately, it helps to save the overall operative time of the patients. Many times we also use these models to get oriented intraoperatively while performing the surgery. So the journey of 3D printing is started way back in 2016 with under able leadership of Professor Sinha when I was the resident. And we published our experience in JOCN with good remarks. Here are a few examples which we have treated for the CVG trauma in a patient, young male, having CVG trauma with atlantoaxial dislocation, hangman fracture, managed surgically with preservation of the bilateral ganglion. One more patient having CVJ trauma with compressive myelopathy with rotational abnormality with odontoid fracture, managed surgically with excellent results. One more patient of rotatory subluxation of CVJ C1, C2 with odontoid fracture, managed surgically with C1, C2 screws with excellent result. One more patient is showing patients of CVG trauma with type 2 odontoid fracture. Patient is subjected for the odontoid screw. They are showing the screw purchase in the both segment. The usefulness of the 3D printing model is not limited only to the trauma patients. It also is very useful in the patient of CVG normally, who is many times we find they're deficit exaggerated by the trivial trauma. So here is a 5-year-old boy with severe compressive cervical myelopathy, CVG myelopathy. Here is the coronal alignment. Here is the sagittal alignment with compression. 3D study shows the deficient posterior element with abnormal vertebral artery going all over, exact over the joint over the left side. Here anterior part is showing the sagging of the C1 over the C2. Patient was managed surgically. It is well funnel-shaped spinal canal with coronal alignment and all those. We can appreciate the coronal alignment from the anterior view also. Here the sagging is completely removed. So the every technology has their own limitations. 3D printing is also having its limitations. Because of the lack of the soft tissue elasticity, it's not replicating the actual relative movements happening over the C1, C2 joint while we are doing the performing the surgery. But this is largely overcome by the techniques like multi-material, multicolor technology of the 3D printing, which is nowadays practiced very widely. It's also having some time-consuming workup in the pre-op period and imposing some monetary issue on the patients. So to conclude, I would like to say the 3D printed models are more pragmatic means than the computer graphics images, as these can be held physically, rotate, visualize in all dimensions by the surgeons. And use of 3D printed model to practice can be of immense importance because practice makes man and obviously women's perfect. The fascination for the CVJ surgery, but are afraid of the potential complication is the real indication to get a print the customized 3D printed models for CVJ patients. With this, I would like to invite all you for our annual event, SGPJ Neurosurgery Foundation celebration, being held 19 to 21 April 2024. Thank you.
Thank you, Dr. Pawan. A very nice presentation. Here we end the session of pediatric TBI. And because of lack of time, we may not be able to take more questions, but there will be few questions we can take. Yes, sir. Dr. Ashok Gupta.
If you are having navigation and OT, then what is the utility or advantage of this 3D printing?
Pawan, please.
Yes, sir. I definitely agree with your question. Your fact, in fact, if we have navigation, definitely there is no role of 3D printing. But at the same time, we know that in our country, we are having very few centers with the...
No. My question is, if you are having neuronavigation, OARM in your OT, then what is the utility of...
No, sir, the other use of it is, as I mentioned in my learning cycle, when we are imparting training and practice to the students, then it can be useful in the training session, especially in the skill lab. For that purpose, we can use it.
I've got 2-3 questions.
Okay.
I'm still sort of confused. Is there evidence base for the hypothermia? Because so far my understanding goes, we are not sure whether how much hypothermia, yes. So that's question number 1 for the learned people to answer. And I really thank Girish for that beautiful article, the way you show the underprivileged and privileged. That's something which we can't ever do. But you have got all the data. That's the beauty of your place. I mean, I admire you. The only thing you didn't talk about the shaken baby syndrome and all those things which come there. So that is also quite more, I think, in the underprivileged group. And am I right? Okay. And the other thing is that what's the proportion of the population? What's the percent of the population underprivileged and the lesser privileged and the better privileged group? Because that proportion itself would change the figures. So that probably also can be added to the whole thing, that 80% are underprivileged, or 40% underprivileged, and how do they fare? So I would like comments on that. Thank you. So the hypothermia part.
Yeah, the hypothermia, it is recommended, but not moderate hypothermia. It's mild and it's with strict thermoregulation, so it's to avoid hyperthermia. So not much less than 34 to 35 degrees centigrade. There's no evidence to prove that that works. That's what the consensus algorithm was that strict temperature regulation, normal regulation with, if you were going down to second tier therapy, you should consider, there were some class 3, class 4 type papers that used 34 to 35 and showed some improvement in ICP management, not necessarily an outcome.
Yes, Professor.
I enjoyed very much your talk, Dr. Edelson, on decompressive craniotomy, the pediatric population. Sorry, do you want to answer?
No, I was just going to answer. Okay. Sorry. So just to tell you, I don't know whether this is because patients may be going to private hospitals or whatever, but in the emergency department of the NHS system, that's where the data comes from. It's amazing that over 80% of attendances are from group 1. So if we looked at, it was something like 9,500 patients. So 80% of that was group 1. And I think Deepak's data, it was related to falls from verandas and other places. I think probably if they look the same way, they probably find a similar percentage. That's my suspicion.
Yes, Professor.
Okay, now coming to the decompressive craniotomy. What is your feeling about microsurgical opening of the cistern in the pediatric population? Just a feeling.
Well, my overall feeling is that for certain patients it may be useful and in others it may not. I don't think we have the data to support it yet, and particularly in children. I do know, for example, when I do the bifrontal and bicoronal decompression, do frontotemporal, I'll take the anterior sagittal sinus, and when I take the Follex and now start to drain CSF, the brain really relaxes. And so I do feel that there is some early basis for its use. I don't think it's to the exclusion of one or the other, but I just don't know if we can define yet the subpopulations that would benefit from it.
Any other question? in most of the trauma patients, how many of us are using Trenexa injection, tranexamic acid at the time of injury? Because I have seen some of our speakers have shown acute subdural hematoma with factor deficiency and so many things. But I'm sure many of us are not using tranexamic acid as. So I think it has been recommended in the guidelines that in trauma patients, without even knowing this, because this is not harmful, but it can prevent the more accumulation of blood. So anybody like senior people from Peter Hutchinson, I think he's here. Professor Peter, he's not here. So anybody else who is using it? No? Professor Pathak?
We were discussing actually, I mean, it's in the susceptible patients, not really directly in the guidelines, So we cannot sort of interpolate that in the guidelines as such, but in susceptible patients, probably in small subject, you can think of that. But routinely, I'm not very sure. There are other colleagues of mine to comment on that.
Thank you, sir. So here we end, Dr. Sinha, Professor Sinha, sir.
Dr. David, you do decompressive craniotomy in children. So post-operative changes like hydrocephalus, Schenken syndrome, or cranioplasty resolution hydrocephalus, how they are different from adults?
We tend to see a lot more of the post-traumatic hydrocephalus in those instances. But it quite varies. It's really, I believe, more the extent of injury and as well, again, depending on age and those types of things. I think there's challenges with regards to the decompression in very, very young children. I used to just take the bone out, but in the infants now, because of the flexibility of the skull, you can hinge it. And so, you can sometimes avoid some of the real cave-in type of decompression, but I don't, it varies from patient to patient, and I'm as guilty as the next person where, what worked for you last. And I would really like to see, similar to what was mentioned, this sort of a registry and the ability to sort of develop that data. I know we have the ADAPT data, and that's something that I'd like to get written up, and I think that might help guide sort of the next set of studies.
So should we conclude here? And from the next proceedings, Professor Sinha will announce.
Thank you, chairpersons.
Thank you.
So we now come to an end of what actually turned out to be quite an enriching and innovative conference. I hope you enjoyed your stay at our beautiful city. I now request Dr. Dhaval and Dr. Chopra to give away the prizes for the quiz that was held today morning. So the first prize goes to Dr. Mohit Gupta. The second prize goes to Dr. Paurush. And the third prize goes to Dr. Akshay. Thank you, Dr. Dhaval and Dr. Chopra. I now request Dr. Ashok Gupta, Head of the Department of Neurosurgery, SMS Medical College, and the Organizing Secretary to say a few words.
Good afternoon, dear friends. ICRAN 2024 turned out to be a fantastic platform for all of us to interact with experts, network with fellow professionals, and learn about cutting-edge research technologies and recent advances in management of neurotrauma. It was wonderful to see all of you in our beautiful pink city of Jaipur, and hope you enjoyed the hospitality and ambience and rich heritage of our city. We hope that our sincere efforts made your stay comfortable and enriched you scientifically. Wishing you all a wonderful time ahead and hope to interact with you all soon. And at the end, I thank to my department, my colleagues, and my residents for wholehearted support for this conference. Thank you.
Thank you, sir. Mr. G.S. Parekh would like to say a few words, so I request him to please come up.
नमस्कार। पहले तो मैं आप सभी लोगों का गुलाबी नगरी में स्वागत करता हूं और मैं जीएस पारेख, कई लोग मुझे अभी 4-5 दिन के अंदर एज ए डॉक्टर के हिसाब से पुकारते थे, लेकिन मैं डॉक्टर नहीं हूं। मैं एक छोटा सा स्मॉल टीम मैनेजमेंट हसीना साहब की उसका एक छोटा सा आदमी हूं। मैं खाली 2-3 मिनट लूँगा। जयपुर में मुझे करीबन 50 साल हो गए और इस न्यूरो को खास करके ऐसा मैं सच मेरा बहुत लगाव रहा है, मेरा बहुत जुड़ाव रहा है। और मुझे वो दिन भी याद है जब 81-82 में अंदर मेरा एक छोटा सा एक्सीडेंट हुआ था, तो डॉक्टर सरीन साहब हुआ करते थे उसमें, और 3rd फ्लोर पे एक छोटा सा डिपार्टमेंट था। आज आपके सामने बढ़ता बढ़ता ये कारवां बांगड़ एक वर्ल्ड फेम हो गया। बहुत ही खुशी की बात है और इसमें और बहुत ही कर गुजरने की भी आवश्यकता है अभी, जो बराबर निरंतर प्रयासों से होता रहा है। बहुत खुशी की बात है। जहाँ तक मैं 1 मिनट शेयर करना चाहूँगा, डॉक्टर वीडी सिन्हा से की बात है, मेरा आपसे जुड़ा हुआ था 1990 में। 92 में मेरी सिस्टर इन लॉ का ऑपरेशन करवाया था। रात को साहब 1 बजे पधारे थे और बचने के चांस थे उसके 1%। साहब कहता कि पारेख साहब आप साइन कर दो, 1% चांस है, लेकिन भगवान के दया से उस ज़माने में इनको 4-5 घंटे लगे और बहुत ही सक्सेसफुल हुआ। मेरे फ्रेंड्स में और या तो मैं आप यूँ के लिए शौक है, एक को जनता वाली वो वाली बात नहीं है। कम से कम सिन्हा साहब से 10-15 ऑपरेशन करवा चुका हूँ, स्लिप डिस्क के और उसके, लेकिन सारे सक्सेसफुल रहे। और हाँ, तो उसके लिए बस मैं 1 मिनट लूँगा सर, और कुछ नहीं ये है। और एक बात मैं ये कहना चाहूँगा कि सिन्हा साहब से, वैसे मेरे से 2 साल छोटे हैं, मेरी दोस्ती भी है, मेरे समझी भी है, सब कुछ है, लेकिन सीखने का बहुत है। जब मेरी एनर्जी कम होती है और मैं साहब के पास पहुँच जाता हूँ तो मेरी एनर्जी बूस्ट हो जाती है। ये एक सीखने की चीज़ है, इनको चाहिए का वो सबके लिए लागू है। परफेक्शन इनका मोटिव है, हर काम एक परफेक्शन से होना चाहिए और बहुत बड़ी बात है ये। और मैं छोटे से शब्दों में ये कहना, क्योंकि समय की बाध्यता है, सिन्हा साहब मेरे को इशारा कर रहे हैं, बोलने के लिए कई घंटों बोल सकता हूँ, लेकिन सिन्हा साहब एक यूनिवर्सिटी है अपने आप में। अगर इनको सीखो तो बहुत ही कम है। और मेरा पर्टिकुलर लास्ट के अंदर मैं ये कहूँगा, न्यूरो के डॉक्टर्स है, उनसे मेरा क्या पता भगवान की तरफ से नाता है एक तरह से। सरीन साहब से लेकर के इनके सारे HOD देखे हैं, सबसे मेरी दोस्ती रही है, किसी से कम किसी ज़्यादा। अशोक गुप्ता जी, चोपड़ा जी, डॉक्टर अमित चक्रवर्ती जी और भी है। और जो SMS में काम किए हुए हैं वो आज डायरेक्टर और HOD प्राइवेट हॉस्पिटलों में लगे हुए हैं। बहुत ही खुशी की बात है बांगड़ के लिए। और मैं सारे जो न्यूरो के हैं उनके लिए आप सभी लोगों से एक रिक्वेस्ट करूंगा छोटी सी, 1 सेकंड के लिए इनके सभी के लिए इनका रेस्पेक्ट करते हुए ताली बजा करके क्लिपिंग करके इनका स्वागत करें। थोड़ा सा फार्मा वाले बैठे हैं, खड़ा होकर के इनका वेलकम करके स्वागत करके ये मोटिवेट हुए। और लास्ट के अंदर मैं आपको बता दूं, ये जो शरीर अपने को दिया है वो भगवान ने दिया है, लेकिन इन लोगों को भेजा है ना, ये भगवान के छोटा रूप हो जाएगा। ये दूसरे वर्ष में अगर कहो तो भगवान के दूत है, ये अपने शरीर की रक्षा के लिए इन्हीं को भेजा है अपने लिए। तो बहुत बहुत इनको धन्यवाद, बहुत सफलता रही। और मैं टीम मैनेजमेंट का पार्ट था, हमारी तरफ से कोई गलती हुई हो और हो तो उसके लिए वेरी वेरी सॉरी, पूरा ध्यान रखा गया था। थैंक यू।
Thank you, Parikh sir. I now request Dr. Andrew Reisner to share his thoughts about the conference.
I mean, just say a few quick words. First of all, starting to tell you, Virendra, Amit, Ashok, and your committee, as well as the larger Indian Neurosurgical Society, what an absolute honor and a privilege it has been to be with you here the last few days. All of us from the WFNS and those that don't belong from the WFNS came here as colleagues. I'm speaking about all 30 to 40 international participants of this conference. And I want you all to know we came here as colleagues and we are leaving here as friends. Specifically, I'd like to thank my colleagues who are current members, future members, past members of the Neurotrauma Committee, but all of whom are involved in the WFNS. And I'd like to particularly thank Dr. Andres Rubiano from Colombia, Peter Hutchinson from the United Kingdom, David Adelson from the United States, Deborah Garazoro from Dubai, Yves Sai from Canada, Hiroshi and Aiki from Japan, Deepak Gupta from India, Ahmed El-Fiki from Egypt, Salvatore Chabaro and Corrado Icarino from Italy, Lynn Lucina from the Philippines, Guri Solansky from the United Kingdom, and last but not least, Maximilian Medhorn from Germany. And apologies if I've left anybody else. But I think this long list should say to you all how much we respect, how much we admire you, and how much we are so glad to be part of your fraternity. Thank you so much for a wonderful conference. I'll end off by saying if this conference was a scientific paper and I had to give just the key words or phrases, it would be this. An incredible warm hospitality, and it's not only from you, but your spouses as well, and I think your spouses especially need a round of applause for the many hours that you've put up. Thank you, Mrs. Sinha. So to be warm hospitality, excellent science, and just know it is our honor and a privilege. Thank you so much.
Thank you, Dr. Reisner. I now request Dr. V.D. Sinha to deliver the vote of thanks.
Good afternoon to everyone. And at the outset, I want to thank World Federation Neurotrauma Committee and WSNS for giving this opportunity for hosting this meeting. And I'm thankful to World Federation Committee, Dr. Andrew Reisner, Dr. Andrew Rubiano, Dr. Raymond Cat from WSNS, and Dr. Basant Mishra. He was our national coordinator for this meeting. And all of them, they worked very hard with me for last 1 year for managing the speakers and planning this conference. And I'm very proud of my SMS Neurosurgery department under the leadership of Dr. Ashok Gupta that they cooperated me like anything, and I cannot forget in life their cooperation for making success this conference. Dr. Chopra is another colleague. For last so many months, he's coming every day to me for asking the work for this conference. Dr. Chopra, I'm thankful to you. And I'm very proud of telling you that we have workshop that was having 2-part, microanatomy and this TBI course. In microanatomy, the microdissection, it was done first time in the world where the Medtronic, Sanam, Esculap, and Stryker, and this Heber, all companies cooperated us for instruments and all. I must thank all these companies for making their efforts, for making the first conference of the world where all the instruments were used first time in this workshop. Second part of this workshop, we had a course, and I'm thankful to Dr. Andrew Rubiano. He planned everything, and it's worked very successfully, and definitely it will help the developing and underdeveloping countries for management of the pre-hospital part. Scientific committee of any conference is the base for making success of this conference. So I must thank Dr. Amit Chakravarti. Can you stand? Is he here? Dr. Amit Chakravarti, Dr. Gaurav Jain, please. Dr. Anil is here. Where is that? Dr. Anil? Yes. Dr. Bika, Dr. Jitin, and Dr. Priya. She is the very basic. So I must thank all of you for making grand success of the scientific program. First time in ICRAN, the nursing session was taken. And I'm very proud that 55 registration we had from India, from abroad, and we had a very good nursing program. And this nursing program was done under leadership of Dr. Gaurav Jain. And we had a delegate from the Australia, Malaysia, and different part of our country. And because nurses are very important part of the trauma, patient's care or any patient care, because in trauma cases, in ICU, they see very closely this patient, they watch the patient, they give drug the patient, they feed the patient. So they are very important part or backbone of our system. So we added them for this meeting first time, and it was grand success of the nursing session. Then I cannot forget the event person, Mr. Gaurav, Anuj, and Anuja, and Junior Gautam. So they work hard very much with me for making this successful. As for the transport, Dr. Anil and Dr. Anil Sharma and Dr. Dishant Sharma, they worked very hard for last few days. So till now, I have not had any single complaint or irregularities about this part. Then hotel staff, they were very cooperative, and I think they were with their best of their efforts. Media is also very important, and I must thank Mr. Govind Chaturvedi. He's a PTI person, then Patrika, then he has joined a lot of places. He coordinated the media, and I think had a very good coverage every day on electronic and paper media. Finally, nothing can be done without money. So I cannot forget the company people, the Sun, Micro, Esculap, Ethicon, GE, Jesco, Medtronics, Sanma, Global Instrument, Haber Surgical, Icon, Stryker, Intas, Jeon, Jais, Kanta Surgical, Minimax, Munmun, Pitkar, Platinum Healthcare, Premier Surgical, Spine and Joint, and Joyce Company. I think thanks to every company for their financial support, financial, moral support, and all the support, whatever we told them, they were with us. I'm thankful to all of your companies for this. And I hope all of you had good memories. You will carry good memories. You will remember this meeting. And please keep on meeting. Thank you, everyone.
Taken all the trouble. I have to thank her on your behalf. Thank you.
So I guess before we move for lunch, we can all give Dr. Jyotsna Sinha a huge round of applause.